All right, so good morning, everyone, and welcome to the 2025 Living with Melanoma Patient Symposium, hosted by AIM at Melanoma and UT Southwestern Medical Center. My name is Dr. Daniel Wang. I'm a medical oncologist here at UT Southwestern and co-lead our melanoma program. So this is actually our first symposium at UT Southwestern, and we're very delighted to have AIM at Melanoma provide such a platform for us to engage with our patients and caregivers from the Dallas-Fort Worth area, as well as the hundreds of other participants that are joining us online all over the world. First, I'd like to thank a few people. So this event wouldn't have happened without the help of AIM at Melanoma, especially Ann Garst and her team to help us bring this event live in Dallas. I'd also like to thank our team here at UT Southwestern, including Tiffany Bradshaw and Jada Johnson, who helped lead the charge here. And just for some housekeeping, there are many of you guys online. If you are joining us today via Zoom, please place your questions in the Q&A tab, which is going to be located at the bottom of your screen. And for those of you joining us on AIM at Melanoma's Facebook and YouTube live platforms, if you don't mind putting your questions into the comment sections, and we'll have a member of our team transfer them to Zoom. So it's truly an honor for us to be here and have you here as well, to come together to learn about the advancements that we've made with melanoma care. Whether you're a patient or a caregiver or even a healthcare provider, we're hoping that today's event will be sort of a beacon of knowledge and hope for those of you with this daunting disease. We know that melanoma is a deadly diagnosis, but it's really important that we remember that every step we take in understanding the disease will help us get closer to better treatments and ultimately to a cure. A little over 2 decades ago, when AIM at Melanoma was founded, advanced melanoma was considered a death sentence. But now with the advent of new therapies like immune checkpoint inhibitors and targeted therapies, we're seeing patients that are still doing well 5 years and even 10 years from their diagnosis. So this has really radically changed our view of the disease. But the reality is that half of our patients don't benefit from these treatments, so we still need to make huge strides to bring this benefit to all of our patients. We also know that many of our patients also don't have advanced melanoma. So today you're going to hear from some of our experts from the field on the latest melanoma research, from treatment options to how to manage the challenges that you may experience as you're going through your journey with melanoma, starting from diagnosis, surgery, systemic therapy, and also the side effects that you may experience with these types of therapies. We'll also touch upon a rare type of melanoma that hasn't seen as many of the benefits as we've received for cutaneous melanoma. And we're very lucky to have Dr. Johnson from Vanderbilt University joining us today virtually to give his expert perspective on immunotherapy and their toxicities. Now, we do understand that every one of you has had a unique journey, and we encourage you to ask questions during the Q&A session and engage in discussion and hopefully connect with fellow patients and caregivers and some of the health providers that you've worked with to discuss some of the experiences that you've had. We're hoping by coming together, we can sort of empower ourselves with knowledge and also create a network of strength and hope. Finally, I'd like to thank you all for being here today, and we're really excited to share what we've learned. And we hope that today's symposium leaves you feeling more informed, supported, and hopeful about the path forward. So with that, let's get started. So our first speaker is going to be Dr. Jennifer Gill. She is one of our excellent dermatologists and leads our melanoma program in the dermatology clinic. She's a physician scientist with years of expertise in the research of melanoma and its metabolism. So without further ado, to introduce Dr. Gill.
Good morning, everyone. Thank you so much for joining us. Today, I'm going to be talking to you about what I consider your action plan for melanoma and a checklist of things to do from your dermatologist. So first of all, I want to start by welcoming you, but also congratulating you. It's very challenging when there's so many things in our health and with our lives that are out of our control, but really educating yourself and learning as much as you can about where the field is and where we're going can really help empower you as a patient and your loved ones. So I'm going to start out first by talking a little bit about the natural history of melanoma to kind of give you a framework. And as a physician scientist, I think a lot about what's happening at the molecular level. And so I think it's helpful for patients to kind of have an idea too of what's going on. So in your normal skin, you have these wonderful little cells at the bottom called melanocytes. They are few and far between. Their job is to make melanin, these little dark granules that get sent out to all the cells in your skin. The job of those melanin granules is to sit almost like a little umbrella and parasol over the nuclei of your cells. And that job is to really protect those cells from DNA damage from the sun. For patients who have really, really light skin, their melanin granules are often a little fewer and far between, and they're lighter. For people with darker skin, they have a lot darker melanin and many more melanin granules that are protecting their cells. Now, what happens is when we get exposure from the sun, UV ends up coming down and can impact the DNA in these cells. And over time, our body should be repairing this DNA, but doesn't always do the best job and can't always do it perfectly. What can happen is many of you know and have seen you can get moles, and these are just several melanocytes that have started getting a mutation and they start growing, but for the most part are behaving themselves. But over time, with more mutations, this can turn into a melanoma. And so, this is something where these melanocytes are no longer behaving. They're continuing to grow and expand. They're destroying the skin around it. And if given enough time and with certain invasive types of melanoma, those cells can even get into your blood or your lymphatics and spread to other places where they set up shop and grow and ultimately are much harder to treat. So there's many things as patients and as physicians along this whole trajectory that we can do to sort of try to take what's in our control to help improve outcomes and the way that we manage this disease. And the way that I put these in sort of 5 different buckets, and they kind of go along this spectrum. I think it's important for all of us to understand what is our susceptibility, first of all, to melanoma and skin cancer. How can we protect ourselves from the sun so we can minimize the UV damage that predisposes us to getting these melanomas? What should we do about surveillance? Many of us, we can't change the past, what our sun exposure is. How do we watch our skin? What should we be doing to look out for melanoma? If we do have melanoma and we get treatments, how do we manage the side effects of those? And then across the whole continuum, some of my recommendations that I think are important is really building a support network. So we'll go through those. But to start out, let's talk about susceptibility. So melanoma, it's important to know, can happen in anyone. It does not matter what your skin type is, but it is definitely more common in patients with fairer skin. So the lighter your skin, the lighter your eyes, red hair, blonde hair, the melanoma is much more common in patients with those skin types. On the other extreme, patients with darker skin are still at risk for melanoma, and their melanomas often occur on areas where skin is lighter or maybe not even so pigmented. So the palms and soles of the feet, even the genital areas, the mouth, places where the sun doesn't always shine are places that people still can get melanoma. Now, exposure history has big impacts on melanoma risk. So when I'm talking to patients, we think a lot about how much time have you spent near the equator or places where there's a lot of UV sun? Have you had a history of using tanning beds? Have you had any outdoor occupations, roofing, farming, lifeguard? Do you have a lot of outdoor hobbies, spending time at the lake or the beach? And importantly, how many sunburns have you had? Do you have a history of a lot of times where you've got blisters or peeling? Those are all things that put you at a higher risk of developing melanoma. In addition to exposures, everyone has kind of clues in their personal history that can also influence their risk. So patients that have had an organ transplant or have other reasons why their immune system might be low are at a higher risk of developing melanoma. Patients that have many moles, more than 30, 40, 50 moles, we know, are at a higher risk. When those moles are atypical and have kind of unusual shapes and sizes, those patients are more likely to get melanoma. And of course, if you've made one melanoma, it is very possible you will make another. Now, while the majority of melanomas we think come from our sun exposure and our risks, there are a small percentage of melanomas that are a result of what we would call kind of cancer genetics or family genetics. These are important questions to kind of think about for yourself and also talk about with your doctor. So we like to know how many of your close relatives have had melanoma, and close relatives being usually parents, siblings, children, and kind of the next step after that, grandparents, aunts, and uncles. How many have had pancreatic cancer? So there are some genes where melanoma and pancreatic cancer go together. That's another question we want to know. And then how many close relatives have had other cancers? We often talk about the rules of threes, which is if you've had 3 melanomas, if you've had 2 and your parent had a melanoma, we start thinking about whether you maybe need to get seen by cancer genetics, or if you're someone that's in a very low risk group, so someone very young or someone with a lot of pigmentation and you have 2 melanomas or someone in your family does, we think about cancer genetics. Now, there's a number of genes. Many of you have heard about BRCA1 or BRCA2 with breast cancer. There's a number of genes we now know are related to melanoma. Why does this matter? If we find out that you or your family member has one of these genes, it impacts the frequency in which we want to screen you, and it also impacts whether you need to be screened for other types of cancers. So in terms of susceptibility, my 3 to-do list tasks for you are to review your skin type and exposure history, your family history, know what kind of risks you come to the table with, modify the risk factors you can, which we'll talk about with sun exposure. There's many things we can't change. And if melanoma or other cancers run in your family, I encourage you to talk with your dermatologist about potentially meeting with a cancer geneticist. Okay, so moving on to sun protection. This is something I spend a lot of time talking about with patients. My first piece of advice is to really be aware of the UV index. UV index is how strong those UV rays are that are coming and hitting your skin. UV index is impacted by a lot of things, especially latitude. If you're down near the equator, that sun is blazing. Altitude, so how high are you up? If you're up on a mountaintop, you're going to get a lot more UV. The season, the time of day, clouds, pollution, ground reflection. These are all things to really keep in mind as you're going outside and spending time. Ideally, avoid that peak day sun if you can, and then you really need to be thinking about how much you need to protect yourself in the context of the UV index. I encourage my patients when we talk about protecting themselves from the sun to really use a layered approach, okay? So everyone, hears a lot about sunscreen. Sunscreen's great. Some of my recommendations are you want an SPF of at least 30 or 40. It needs to be broad spectrum. If you're outside sweating or on the water, it needs to be a water resistant, applying every 90 minutes. There's a variety of sunscreen types, including tinted ones. If you don't like that kind of white pasty look, there's plenty of tinted ones now that help with that. It's important you apply it properly. You need to use enough of it. And I always say the best one is the one you will use. So you really have to take time and find one that, doesn't bother you. Now, sunscreen is amazing, but I really think it is not the workhorse of what we use to protect our skin. Clothing is amazing, and now UPF clothing from what it was 10 years ago has improved so much. There are great UPF clothes. They get rated sort of like an SPF, so UPF of more than 50 is very protective. It's doing, in my opinion, a better job the sunscreen because you don't have to worry about constantly reapplying. Did you miss a spot? And like I said, many of them now are a lot lighter and cooling and work great. In addition, you should be thinking about hats, covering your ears, scarves, sleeves. If you play golf, I have a lot of golfer patients. Those sleeves are UV protectant and work great, sunglasses, and then don't underestimate the shade. Whenever I am out, I love being outside. Whenever I'm outside, I'm also always seeking where is that spot that I can go where it's cooler and I'm also not getting as much sun. So my overall recommendations in terms of sun protection, be mindful of the UV index, take a layered approach, and then really I encourage people invest in some products up front. Just decide I'm going to spend a little bit more money. I'm going to buy 4 or 5 different sunscreens. I'm going to buy a couple of these different shirts, figure out what I like, and that's really an investment going forward. Okay, so surveillance. So your skin history and sun exposure history is what it is. Some of you may have moles, some of you may have a history of melanoma. What do we do in terms of monitoring our skin? So it's important everyone has a surveillance strategy. I consider surveillance strategy falling under two arms. One is what you do yourself to watch your skin, and the other is what you need to do in terms of getting a professional to help you. So what you can do yourself, we do recommend in terms of skin checks that you try to look at your skin once a month. Many of you have probably heard about the ABCDE rules. You can find this at the AIM at Melanoma website. These are kind of the things to look out for. We also have some other rules that are a little bit less known. We call it the ugly duckling rule. So if you see a spot on your skin that doesn't look like any other spot on your skin, you need to bring that up with your dermatologist. The non-healing rule, if you have what you think is a pimple or a sore that just will not go away, that's another warning sign that you should have it looked at. I put on here, make sure you look where the sun doesn't shine, because melanoma can happen anywhere, and you really need to know your body and recognize if something is new or doesn't seem like it belongs there. I always encourage patients to what I call high alert zones. So areas on your body where you have had a melanoma, where you have a scar from your melanoma, that whole vicinity we know is a little bit at a higher risk of getting a new melanoma. So keep a close eye on that. And then of course, lymph nodes in those areas. If you aren't sure about a spot, I tell a lot of my patients this because, this is a lot to be looking at your skin and monitoring. If you have something that catches your eye, take a photo of it. We have amazing, smartphones now. Take a good, clear photo and keep an eye on it and look over the course of weeks to a month and see if it's changing. And last and most important, if you're not sure, contact your doctor. It's not your job to be able to know whether something is a melanoma or not. We just want you kind of being on the lookout. Now, when it comes to professional screening, I would encourage you to seek out a board-certified dermatologist. These are people who go to school for many years. I can attest to that and see lots and lots and lots of patients in their skin. If you're high risk, and high risk being someone that has one of those cancer mutations that we talked about, if you have a history of having melanoma or many, many atypical moles, I would say consider seeing someone specialized in pigmented lesions or melanoma. The guidelines are rapidly changing. You want to ensure you have a doctor that is accessible to you. Okay, it's very, very hard right now in healthcare. Wait times are very, very long. The system can be clogged. And for someone that has a spot that's concerning to them, we don't want that sitting on you for months and months. So find a doctor that can get you in and is willing to see you quickly. And then work with your dermatologist to determine how frequently you need to be seen, once a year or more often. When I do skin checks on patients, I use that tool that's right up there often. It allows me to be able to kind of magnify and look at a mole very close and have a better sense of whether it may be concerning or not. And we often use things like photography and mole mapping as well. So in terms of developing your surveillance strategy, my recommendations are get familiar with all your skin, monitor it monthly. If you're unsure about a spot, take a photo and watch it, and then identify and meet with a dermatologist for skin checks at regular intervals. All right, side effects. So there are side effects related to all the things along the spectrum, and we're going to briefly go through those. So first, some patients develop sunscreen allergies. I'm telling you to protect yourself from the sun. I have patients that do such a good job and unfortunately sometimes find that they're allergic to sunscreen. Commonly, this is fragrance that's in sunscreen, so I encourage you to use sunscreens that are fragrance-free. Sometimes it's the actual chemical sunscreen component. If you think you might have an allergy to sunscreen, the best ones to use are the ones that are physical sunscreens. So their active ingredient is titanium oxide, zinc oxide. You can find these in more of the infant children area often, in addition to the adult sunscreen areas. Scars. So Dr. Dan's going to be talking to you about different surgical approaches to get rid of melanoma. Some patients are very prone to having keloids and hypertrophic scars. Because melanoma scars can sometimes be long, these can be, really bothersome to patients. We have tools in the clinic to be able to treat these scars to try to minimize the symptoms associated with them and make them not quite so large. Radiation for patients that are receiving radiation, sometimes the skin can be affected by this. Your dermatologist has several tricks in their toolbox to help kind of really improve this and make this more manageable. Some of it is the tincture of time. And as patients now, so many new therapies have come in for treating advanced melanoma and systemic melanoma, and many of these have side effects. So patients that are on BRAF or MEK inhibitors, we know have a variety of skin side effects. Some of these can be sort of acne-type lesions. Sometimes it's changing of moles. Some people develop actually a different type of skin cancer while they're on these medications, and so making it even more important that you see a dermatologist and that's helping watch out for these. For patients on immunotherapy, so patients receiving these various infusions, these boost your immune system. It's great when your immune system is working against that cancer, but a lot of times it also starts working against other things. So one of those, the most common in melanoma patients getting treated with immunotherapy is vitiligo. This is where your body in the process of fighting the melanoma cells sometimes gets a little bit confused and starts fighting the normal melanocytes in your skin, and that can leave these white patches. The good news is that we do know people that develop that. It often means the immunotherapy is doing its job and your immune system is working well. Other things that are very common on immunotherapy, lots of patients I see with just dry skin, itchy skin, and immunotherapy rashes can really be any type of skin issue like psoriasis, eczema. Most of the time are not super severe, but it's important you get seen early so we can take care of things. Now, this I put on here, this is not a side effect of treatment, but it is something that I like patients to be aware of. A lot of my patients who are on immunotherapy are under the assumption that because they're on immunotherapy, they wouldn't be developing a new melanoma. But the data shows that's not entirely true. So about 5% of patients that are on systemic immunotherapy for a melanoma that's inside of them can develop a new melanoma on their skin. So it's important that even though you're undergoing these treatments, you still see a dermatologist to look out for new spots. We don't want you to have to fight a second melanoma. So in summary, the to-do list for side effects: use products for sensitive skin, minimize fragrance or unnecessary products. If you develop a cutaneous side effect while you're on any of these melanoma treatments, contact your dermatologist early. It is way easier for me to help you with the problem at the beginning than after the cat's out of the bag. And then continue getting skin checks, even if you're receiving immunotherapy or systemic therapy. Okay, the last thing I just want to touch on is support. I think, having any kind of cancer diagnosis and can be a really a big struggle. And so I think, support is something that's super, super important. I talk to patients about this a lot. So the first message I'd like to tell you is to take care of you. So a cancer diagnosis is scary. You are taking the first step. You are empowering yourself with knowledge. I have this to-do list for you because I want you to think about the action items and the things that you can do. Importantly, do not be afraid to go outside. Okay, I have so many melanoma patients that begin to feel so concerned about UV and the sun that they no longer enjoy their hobbies. They don't go outside. Don't do that. Like you can still get outside, enjoy your life, spend time out in the sun. Just do the things that we talked about to protect yourself. It's really important to find medical professionals on your team. Like I said, it is not your job to be able to look at a spot and know whether it's a melanoma or not. That's my job. The reason why we have you come back for these skin checks is because, that's my job to find those spots on you. I just think it's a good idea for you at home to kind of also know if something's popping up and new. Choose a team that's knowledgeable, that knows the newest research and is accessible to you. Like I said, you need to have someone that you can get into the clinic, and you want to make sure they're on top of all the new things. And then consider getting involved with the melanoma community. It's such a special group of people. I'm always so inspired by my many patients. Consider volunteering. These things are also, I think, really good for our souls, to be around other people and supportive of one another. I would encourage you to think about donating to melanoma research efforts. There have been so many strides in this field over the last decade, and many of the things that we treat patients now did not exist when I was in medical school. Consider participating in clinical trials, not just for you, but because providing these samples help researchers like us better understand the disease, and then really educate others. So I can't tell you how many patients come to my clinic and say, someone pointed this spot out to me. I was at the store and someone said I should have this looked at. My barber told me to have this looked at. And a lot of times that's how we catch melanoma. And so really, really be there to help educate other people. So in terms of your support network, take care of yourself. Don't let a melanoma diagnosis stop you from living your life. Partner with a board-certified dermatologist that you trust, and really consider getting involved with the melanoma community. This checklist is all the things that we talked about today. It will be available online in the video. I would encourage you to kind of go through it, make sure you're doing all the things that you need to take care of yourself or your loved ones. And then lastly, thank you so much for having us here today. If you need a dermatologist, we just recently opened a subspecialty dermatology clinic here at the Cancer Center at UT Southwestern. This dermatology clinic is specifically for patients that have melanoma, especially advanced melanomas and are undergoing treatments, and also patients that have various risk factor genes. And there's the phone number there if you need to call and get an appointment. I want to also thank AIM at Melanoma for hosting this, as well as I didn't talk about my research today, but the research that we do in melanoma in my lab and across the country and across the world couldn't be done without generous support from many foundations, as well as the National Institutes of Health. So thank you all, and we'll look forward to questions in a little bit. I'll pass it on to Dr. Dan.
So thank you so much, Dr. Gill. That was an excellent presentation, and that checklist is really useful. So next I have Dr. Amanda Dan. She's one of our awesome surgical oncologists here at UT Southwestern. She's also a physician scientist, so you'll see a trend here. So she's going to talk about surgery for melanoma and what to expect.
Thank you, Dr. Wang, for that introduction. Like he said, I'm one of our surgical oncologists here at UT Southwestern, and I specialize specifically in melanoma and other skin cancers from the surgical oncology perspective. But what you'll see kind of in the melanoma community in general and in the broader cancer community, we really like to think of ourselves as kind of a multidisciplinary group. So all the other speakers that you'll be hearing from today, I work intimately with as we make plans that are individualized for each patient. And I know that there are a lot of probably different stages of the melanoma trajectory of patients here in the audience. I want to first of all thank you for being here. It's really important for our patients to be staying educated and up to date. And we love, seeing you outside of the office as well. So when it comes to treatment options for melanoma, we're going to be talking about this throughout the course of the day today. And when we think about cancer treatment in general, often we kind of think of three broad categories. So there's surgery, which is what I'm going to be focusing on today. Radiation as another what we consider local or regional therapy. And then systemic therapies, which we'll talk about in much more detail. But these are kind of the medical therapies that can treat cancer throughout the body. So specifically for melanoma, surgery, I would say, is almost always part of the treatment plan. Radiation is something that we're using less and less as time goes on, as our other treatments get better. And then systemic therapy is used when needed, often for patients with a little more advanced than just the early melanomas. So when you're talking about your melanoma treatment plan, the first step is really going to be making the diagnosis. So Dr. Gill already spent some time talking to us about that, but these are often going to be things that are made, by the dermatologist in the clinic, even your primary care doctor, your surgical oncologist, if you happen to see one of them already. But like Dr. Gill said, you'd be amazed how many people come into our office and say, oh yeah, my wife pointed out this spot, or I was at the grocery store and a stranger behind me said, you should get that looked at. That's actually how a lot of people are getting these diagnoses made, especially in places that they can't check easily themselves or don't know to be doing these skin checks that Dr. Gill was just talking to you about. So when you have a kind of a suspicious spot, the next step is often going to be a biopsy. This will be done by your medical care provider, most frequently a dermatologist, but again, could be your primary care doctor. There's different kind of terminologies we have, different ways that these biopsies can technically be done. But these are usually in-office procedures. So something that your dermatologist will use a little bit of numbing medicine, take the biopsy, it gets sent off for the pathologist to review or the dermatologist to review under the microscope. And then that's when the diagnosis is made. So I actually just wanted to go through with you here an example of what a melanoma pathology report would look like. Because for a lot of patients now, when you get these results, they're actually coming to your patient portal online, sometimes before you actually get a chance to meet with your doctor and talk about the results. So just so you have a little bit of a roadmap here to what you'll see on a report like this, and kind of the things you want to look at. So, they'll start with talking about how the biopsy was done, where it was done. But then the things you really want to focus on and the things that your physicians will be focusing on when they go through your biopsy report with you and kind of what to do next and what to expect. A lot of that is going to be based on what we call the Breslow thickness. That's actually the depth of the melanoma. So how deep does this melanoma go? That's really the primary factor that goes into kind of risk stratifying you and making the rest of your treatment plan, is how thick that melanoma is. There'll also be other things that your physicians are going to think about, what the margins are on that biopsy. And then again, based almost purely on the depth is what's called your T stage or your T category. I know patients will often say, okay, doc, what stage am I? When it comes to staging melanoma, that kind of falls into different categories. The T stage is just based on how thick the melanoma is and some other features of the actual biopsy specimen or the melanoma specimen itself. Then we have the nodal staging, that's your N staging, and the M staging is related to whether or not it's spread anywhere else in the body. But usually when you're actually getting your melanoma diagnosis, the information you have is really based on that T stage. So just so you kind of know what you're looking at when you look at one of these reports. So let's say you've gotten the melanoma diagnosis, what comes next? As Dr. Gill said, this is, always a scary diagnosis, but we want you to all know that there are many teams of people out there to help guide you through this. And, for a lot of people, especially those with early melanoma, this is an incredibly treatable disease. So once you actually have that diagnosis, you'll be either, returned to your provider who made that diagnosis or be referred to a specialist. A lot of times that's a surgeon like myself, a dermatologist. And where we'll start is just by taking a look at kind of the whole body if that hasn't already been done. I will usually be evaluating where that biopsy was done, making sure it doesn't look like there's actually still some additional melanoma there, because that changes a little bit how I think about this. Like Dr. Gill said, we'll do a really thorough examination of your lymph nodes. If melanoma is to spread, usually the first place that it will go is lymph nodes. So your doctor will be providing sometimes a little bit of an up close and personal exam of areas where we know lymph nodes are frequent. And asking you some different questions about some potential symptoms you might have that might tee us off that this might be a little bit more of an advanced case of melanoma. But important to know, usually most people coming in with a melanoma diagnosis are not actually going to have any symptoms. In terms of other additional workup you might be expecting outside of the exam you get in the office, usually this actually isn't indicated, at least initially, for a lot of people coming in with their first melanoma diagnosis. So things like CT scans or PET scans, MRIs, specialty blood tests, usually for most patients, until we have more information knowing that it's indicated, a lot of that's actually not often the next step. So then what are the steps of treatment? Again, I know some of you have already been through some of these steps. Some of you have been through more advanced versions of some of these steps. But just to go through a little bit more what to expect, at least from the surgical perspective, which is often for most patients the first step in their treatment. So like I said, most patients are going to undergo surgery as part of their treatment, but what surgery do you actually need? So I'm going to talk in a little bit more detail about kind of different steps and different components of what might be your surgical care. So the first of which is what's called a wide local excision. Talk a little bit more about that. And then different options we have for surgical management of the lymph nodes. So wide local excision, what that means is we're going to be removing the melanoma or, the biopsy site with a rim of healthy tissue around it. So how much healthy tissue we remove is guided by how deep that melanoma was. Like I was telling you, that thickness really guides how we think about melanoma. So for something called melanoma in situ, which is what we consider a pre-cancer or a potential lesion that could turn into a melanoma, but we don't consider as an actual invasive cancer that can spread, we usually do a pretty narrow margin, just a couple millimeters. And then you can see there, as the melanomas get thicker, we usually end up doing a wider margin. So just to give you kind of a little schematic of what that means, if your melanoma or your biopsy site is there in the middle and you need a 1 centimeter margin around, the tissue that we should take out with the surgery is that bigger circle, the iris of the eye, if you will. But then in order to get these incisions to close nicely, we can't often just take out a circle because a circle doesn't close well. So we end up actually having to extend that into an ellipse, kind of rounding out the rest of the eye there. And so it closes in a nice straight line. So what that looks like in a real person is that was their melanoma lesion there. This isn't actually one of my patients, but a good example of what that looks like. And so the tissue that the surgeon will end up removing is actually that ellipse. So you end up with a larger incision than you might expect from where the spot is, but that's to actually get that skin to close nicely in a way that's going to come together to hopefully make as minimal of a scar or as minimal of an impressive scar as we can. So wide local excisions themselves tend to be usually same-day procedures. So this will be something where you come in either to the office or the operating room, but can often go home the same day. For most people, knock on wood, this tends to be a pretty low-pain procedure. Usually people don't require much more than Tylenol or ibuprofen after this. Like I showed with those pictures, I always tell my patients, and I actually draw out on for them what I plan to do, because you do need to expect probably a larger incision than you might think based on the size of your actual melanoma or the biopsy. And depending on where your melanoma is, it might not be just as straightforward as we cut out a little ellipse of tissue and sew it together. Sometimes, especially on areas like the face or areas on joints or different parts of the arm, we can't always get that skin together in such an easy way. So sometimes this does require a more complex surgery where we actually kind of move tissue from one place to the other. Sometimes this requires things like a skin graft. And sometimes this can actually be a multi-step procedure instead of just that one-day surgery. The risks of the surgery for the primary melanoma tend to be the things that you might expect. Anytime we make an incision in the skin, you have a risk of infection. Usually, though, that tends to be quite low. Sometimes these incisions tend to be on a lot of tension because we had to remove a lot of tissue to get things together. So you can have issues with the wound separating or the wound not healing well. Bleeding or a hematoma forming under the skin. And then again, like I said, it tends to be a longer incision than you think. Sometimes because we have to remove not only the skin, but the fat underneath it, you could have a little divot or something like that from where the area is removed. We have ways to address that. And then the possibility that you could have the surgery and then still have positive margins and potentially require additional treatment are always things I like to make sure my patients are aware of. The other part of the surgical management that a lot of people will undergo is what's called a sentinel lymph node biopsy. So the purpose of this part of the surgery is to assess whether or not melanoma has spread to the lymph nodes. For people that are candidates for a sentinel lymph node biopsy procedure, often this is done at the same time as the wide local excision of the first melanoma, if this is kind of all being diagnosed at the same time. And important to know, this is really a procedure that's to gain information that's going to guide the next steps in your treatment, rather than a surgery really specifically focused on removing a lymph node with cancer in it. So to just give you a little bit more information about how this procedure works. So your melanoma site, or the biopsy that resulted from diagnosing that melanoma, is going to be injected with a dye. There are different techniques to do this, different ways to do this, but most frequently, this is actually what we call a dual tracer, meaning you have two different dyes. So one is actually a radioactive dye that will be injected by specialty radiologists. Then that dye, you can see here, this is if you had a melanoma kind of on the flank or a melanoma on the leg. That dye then travels through your lymphatic chains and gets hung up in a lymph node. Most often that's 1 to 3 lymph nodes. In the operating room, the surgeon themselves will also usually use another dye. This is sometimes a blue dye, one that we can visually see with our eyes, something called ICG, which is a fluorescent dye, which we can identify with specialty cameras. But the goal is to have these dyes help us identify the lymph nodes that would be the most likely ones to have cancer cells spread there if they had spread. It's really important to know that if we identify lymph nodes that are blue or lighting up with this radioactive dye, does not mean that the cancer has spread there. It's just our way to identify the lymph nodes that would be most likely to have that happen, so we can be really targeted in the surgery to remove the lymph nodes. I also like to clarify with patients that we use the term biopsy, which I think is a little bit misleading as a name, because most people hear biopsy and they think, oh, stick a little needle in it. But this is actually a surgical procedure where we need to make an incision and go in and fully remove the lymph node or lymph nodes that we identify with our dyes. Because what the pathologists are often looking for is actually just little microscopic spots of cancer within the lymph node. So you can imagine if you had a lymph node that's about the size of a bean and you stuck a little needle in it, you could easily miss a little spot of cancer. So we actually have to fully remove the lymph nodes so that they can be really thoroughly evaluated to know whether or not there's evidence that the cancer has spread there. Because again, that will affect kind of what we do next, and some of our other speakers will talk about. So in terms of what to expect with this part of the procedure, like I talked about with the wide local excisions, some bleeding, bruising, swelling, pain, infection. Anytime we make an incision, unfortunately, those are always a risk. But things a little more specific to this surgery, you can have what's called a seroma. This is one of the most common things that we see. Basically, it's a little bit of fluid accumulation where the lymph node was removed. Usually it's not dangerous. It will actually go away on its own, but occasionally we actually do have to drain this fluid if it's bothering you. The thing that we can also see is something called lymphedema. So what this is actually long-term or even permanent swelling. If this were, lymph nodes in the armpit, that could be in the arm. If it's lymph nodes in the groin, this could be in the leg. We have many ways to manage this, but it is one of the more annoying side effects, and sometimes can, actually be pretty life-affecting from this kind of procedure. Luckily, this is actually quite low, and I would say, the numbers we say are 2 to 10%, but knock on wood, I think it's actually, in reality, quite a bit lower than that. Depending on where these lymph nodes are, there are sometimes, especially in the armpit, nerves that run through that area that could theoretically be injured. Some people can have allergic reaction to these dyes that I was talking about. That's rare, but it can actually be quite severe allergic reaction. Again, we know how to treat that. We're familiar with how to treat that, but it can turn what's a pretty straightforward surgery into something that can be a little more complicated. And then this concept of a false negative, which means we take out a lymph node, there's no cancer there, and we say, okay, your lymph nodes are clean, but you might actually have a lymph node elsewhere that has cancer in it that wasn't picked up with this surgery. So the real question that, and I spend a lot of time in my clinic talking to patients about this, is who needs a sentinel lymph node biopsy? So for patients with that melanoma in situ, that pre-melanoma, or patients with really thin or low risk melanomas, we consider that less than 5% chance that it's spread to the lymph nodes. Those patients generally we do not recommend a sentinel lymph node biopsy for. The thought is that the risks of the procedure are probably higher than the likelihood that we're actually going to get information that's going to change what we do. For patients that are more in that intermediate range, around that 1 millimeter mark, or a risk of spreading of about 5 to 10%, that's really a conversation you're going to have with your surgeon. So these are actually sometimes the longest conversations I have in the clinic of, whether or not we should do the sentinel lymph node. For a little bit higher risk melanomas, those thicker melanomas that have a 10% or more chance of spreading to the lymph nodes, we will generally recommend a sentinel lymph node biopsy in that case. Although just like with most things in medicine, this is always very nuanced. So depending on, risks for the individual patient or specific risk factors of their melanoma, we might be pushed one way or the other. And these numbers are not exactly strict guidelines. So one of the other surgeries I want to talk about, which luckily is becoming less frequent as we get better treatments for melanoma, is something called a therapeutic or completion lymphadenectomy or lymph node dissection. This is where instead of going in to remove just a few lymph nodes, we'll actually remove the entire lymph node packet or all the lymph nodes in a given area. Again, depending on where your melanoma is or where these lymph nodes are, that can be different places in the body. But the most common ones are what we call the axilla, which is the armpit, or the inguinal region, which are the lymph nodes in the groin. So, like I said, the details of what that surgery will actually entail depends a little bit on where those lymph nodes are. There are different techniques for how we approach these lymph node dissections. So that can mean through an open incision. We're more and more doing a lot of these lymph nodes dissections, what we call minimally invasively, meaning laparoscopic or robotically. For patients that have lymph nodes that are not just on the surface, but kind of deeper in the pelvis, which is where we will often see those, I will routinely do those surgeries robotically to try to minimize the incisions that patients have. Important things to know, and my hope is that this is pretty common knowledge, but for providers providing these surgeries, but I want to mention it because these are things that have changed pretty dramatically in the past 10 years. Having a positive sentinel lymph node, meaning when we do that procedure to remove a few lymph nodes and there is evidence of cancer in a lymph node. 10 years ago, we would then say, okay, you now need what's called the completion lymph node dissection, where we go in and remove all the lymph nodes. That's actually not the case anymore, and we recommend against that. So if you happen, or someone you know finds themselves in that situation and someone says, okay, now you need a bigger surgery, it's just a time to potentially ask some questions, because the complications of that type of surgery are quite a bit higher than just the sentinel lymph node biopsy procedure. Particularly that lymphedema risk and wound complication risk goes from about 2% to up to 30 or more percent. So it is a bigger operation. We do still sometimes need to do it, and it is indicated, but luckily we're not having to do that as much as we used to. So I just want to end by talking about some other new advances in melanoma treatment that really affect how I practice as a surgeon. So we might touch on this a little bit later, but one thing that we're doing now, and this is actually a very recent change within the past year, one of the biggest advancements I would say we have in melanoma is the use of what we call neoadjuvant immunotherapy. What that means is using the immunotherapy actually before surgery in very specific contexts. So what we know is in patients who that's relevant for, and I'll talk to you a little bit more about what that means, we know that the risk of this potentially, of the melanoma coming back, can actually be cut in half if we do the immunotherapy before the surgery to remove the lymph nodes, compared to if we just use the immunotherapy after the surgery. So this really applies to patients that have more advanced melanoma, either at the time of their diagnosis or they have a recurrence of their melanoma, to the point where they have lymph nodes that are not just have microscopic little spots of cancer in them, but lymph nodes that we can either feel to be abnormal, or on PET scans or other imaging, we see that they are grossly abnormal and enlarged on the scans. I mentioned this to you all to be kind of our champions of promoting this information, because what we used to do for these patients was actually take them to surgery and remove those lymph nodes. And even now, after some of this information that says maybe that's not the best thing to do, we do still see that that's happening, because again, this is relatively new information. So if you or anyone you know is someone who falls into this category of, oh, I have a big abnormal lymph node, surgery should likely not necessarily be your next step. And I would recommend that what you seek out is actually a biopsy to confirm that that is or is not melanoma, and then consult with a team who really thinks about this in a multidisciplinary way. Some of the other big advances we have in terms of surgical management of melanoma is really management of the complications of some of these surgeries. So one of those examples is more minimally invasive ways of doing those lymph nodes dissections, as I talked about. The way that we used to do it would be a big incision, let's say in the groin, that goes from basically the upper thigh to the lower abdomen. There are a lot of complications with those wounds healing, with just taking a long time to recover. Now that we can do these in more minimally invasive ways, the recovery time tends to be quicker. We also are getting much better at treating that complication of lymphedema. So UT Southwestern has a specialty program here for this, and many other institutions do as well, of actually offering surgical options to address lymphedema if you're a patient who that develops in. So like I said, lymphedema can be kind of a long-term complication of some of the surgical options we have for melanoma. But if you are a patient who falls into that category, I do recommend you seek out people who are actually specialists in lymphedema, because there might be ways to improve or completely reverse it. So in conclusion, when we think about surgery for melanoma, it is often a part of your treatment plan. So likely if you have a melanoma diagnosis, you will be meeting with a surgical oncologist. But in general, I just want to emphasize that often the surgery is not actually that scary. I want you to feel empowered to ask questions. So for a lot of this, like I said, it is often very nuanced based on a variety of different factors. There's not often always a right or a wrong answer for what should happen with you and your melanoma. So make sure that you're asking questions, that you feel comfortable with your treatment plan. And as a surgeon, my goal is really to provide the most effective and safest surgical treatment I can for you. But as a melanoma doctor and a surgeon scientist who studies melanoma, my real goal is that we get so good at preventing and treating melanoma that you barely need me. And I think, like I have said a couple times, where we have gone in surgical management of melanoma has been completely revolutionized, just in my time as a physician. So 10 or 15 years ago, our routine wide local excision was 3, 4, even 5 centimeter margins, which is an area of skin about this big. And we were routinely doing these lymph node dissections in almost every patient with a, intermediate melanoma, thickness melanoma. And we have now, really been able to kind of walk back and what we call de-escalate our surgical care in a way that I think has really benefited our patients. And I expect that trend will continue. Thank you all for being here.
All right, thank you, Dr. Dan, for such a great talk. We're going to be shifting gears a little bit, and I will be talking a little bit about the management of BRAF and MEK inhibitor therapy. So I am not Tangela Butler. Unfortunately, she can be here with us today, but I will sort of go over this conversation. So these are my disclosures. Let's go to the next slide. So what is BRAF? So this is often a conversation I have with patients when I first see them. And it's something new to many patients. They're not used to hearing about mutations. And what BRAF is specifically in the context of melanoma is a driver mutation. And these are literally mutations that drive the cancers to grow. And oftentimes the cancers become addicted to this pathway and start to spread. So in melanoma, we see about half of patients having a BRAF mutation, especially in the metastatic setting. And when we talk about BRAF, we're talking about a specific part of the gene in what we sort of use as the address. We say V600E or V600K. So when you're looking at your pathology report, these are the things that we're interested in talking about. And why is that important is that we have drugs nowadays that block or target this protein or pathway and actually can cause the tumors to shrink or prevent them from coming back. So how do we test for this? There's actually been a refinement in the way that we test for these sort of mutations. It used to be that we would test only in the tumors that were either biopsied or removed. These would be generally something called a PCR test. And initially, we'd actually only just test for that BRAF V600E or V600K. And over time, we've developed newer testing platforms, something called next generation sequencing or NGS. And these platforms are preferred because we're now able to test not only those mutations, but hundreds of other potential genes and mutations that may be future targets or targets that you could be a part of a clinical trial. In rare instances, we can actually take the tumor that's been removed, put it on a slide, and the pathologist can actually look to see if, specifically to V600E, if that protein is overexpressed, and that's a relatively quick way to get a diagnosis. These other options that I mentioned before sometimes can take a week or more than a week to get a result back. So we usually use that immunohistochemistry for, a quick way to find out. The newest way to test, especially for patients with more advanced disease, is to test your blood. So if you had a biopsy that didn't yield enough tissue for these tests to work, or we need a quick answer, sometimes we will draw your blood. This would be just a simple blood stick, and we're able to send it to other companies that can look for something called circulating tumor DNA. So what we found is that your tumor can actually shed DNA that can give us sort of a profile of the tumor and help us identify this mutation. And so similar to some of the next generation sequencing platforms, nowadays we're able to detect potentially hundreds of different genes and other features that may help us find treatment options for your melanoma. So you'll hear a bunch of different names, and these are kind of listed here, but these types of therapies are oral therapies, meaning they're pills that you take every day. There are both, we talked about BRAF, and now I'm talking about MEK, but essentially what we've discovered over the past decade or so is that if we target BRAF, we can do a good job of shrinking the tumors, but over time, we can develop resistance. So the addition of MEK, which is just another downstream pathway, the combination of those two drugs actually help improve the outcomes of patients compared to just taking a BRAF inhibitor alone. So what you see down here listed are both BRAF and MEK combinations, and I'll talk a little bit about these individually and kind of where they fit into sort of our treatment landscape. So when do we use these drugs? So there's two general settings that we think about when we see a patient about using or offering these therapies. So one would be in the adjuvant setting, so after their surgery, especially if they have stage 3 disease. What we know is that by giving patients the specific combination of dabrafenib and trametinib for about a year, we've seen improvements in outcomes, meaning less cancer coming back. The other setting that we often use these drugs are in the advanced disease, which we describe it as sort of unresectable stage 3, so disease that hasn't spread to an organ but can't really be removed by the surgeon, or in patients with stage 4 metastatic disease where we're not able to remove any of the cancer. And in those settings, we can use any of those combinations. So some of the patients here and some of the patients online have probably received these types of therapies. And so the question is, how well do they work in the adjuvant setting? So one thing that we look at is something called relapse-free survival. This is and what relapse-free survival is really describing is time without any signs or symptoms of melanoma, either any scans or imaging that we use to detect melanoma. So what we're looking here, this is a little complicated, but on the y-axis is the percentage of patients, and then on the x-axis going across is just time. And so this is from a study where patients either received dabrafenib, trametinib after surgery, or they received a placebo. And what we're seeing here is after 3 years, about 60% of the patients that had dabrafenib or trametinib did not still were relapse-free, meaning their cancer didn't come back, compared to the patients that got placebo, which was about 40%. And if we extend that over about 10 years, about half of the patients that received the targeted therapy did not have a recurrence compared to about 32%. So about a third of the patients there that received placebo. So these drugs work fairly well. I mean, obviously, we'd love that number to be higher, but compared to the standard of care about 10 years ago, which was not to do really anything, a close to a 20% improvement is very meaningful for our patients. So in the advanced setting, we can talk a little bit more, and these are just numbers I'll explain a little bit more clearly, but we do see benefits as well. So when we talk about response rates, what we're talking about is major shrinkage of the tumor. So these are patients with disease that we can follow on scans. And when we look at the response, what we're looking for is actual shrinkage. So, that response rate is fairly high, which is around 60 to 70%. And in the context of cancer, that's an outstanding number. And that sometimes these responses are very quick. So patients that are started on these therapies, within days, they can start feeling relief from their cancer, and we can start seeing changes as well. But the issue with these therapies is that they work really well in the initial phase, but how long do they work? And so when we talk about something called median PFS, basically what we're saying is how long were they on therapy before the cancer started to grow again? And you can see here that the median PFS is only about a year. So essentially, if you started therapy for your advanced melanoma, in about 50% of the patients, their cancer started to grow a year later. And in terms of overall survival, meaning basically how many patients, how long did you live after you started the therapy, that ranged somewhere between 2 to 3 years. And also on the flip side, which we'll also talk a little bit more about half of the patients did have some sort of side effect that was serious that they had to be managed with. So while they are effective treatments, there's a lot of caveats on how well they work and sort of how patients manage the toxicities of these treatments. So for patients that come to my clinic, they either were diagnosed with a stage 4 melanoma or advanced melanoma, and they have a BRAF mutation. Oftentimes we have a conversation about what type of therapy to start. And we'll talk a little bit more about immunotherapy, but generally what we say is there's two options. One is to start with immunotherapy or targeted therapy towards their BRAF mutation. And so I'll say that some patients do benefit from targeted therapy first. Like I mentioned, these treatments work really quickly. They have a high response rate, so we kind of know what's going to happen to the patients. And in the clinical setting, what that might look like is, a patient that is in the hospital, is really sick, and we need to start something quickly because, they're not going to make it out of the hospital unless we start something. Or they have disease in multiple areas, and we're just worried that by giving immunotherapy, which sometimes does take a little longer to work, we may run into problems if the cancer does not respond quickly. The other instance where we sometimes will start targeted therapy first are obviously for patients that can't get immunotherapy. So in that context, I'm talking about patients with perhaps an organ transplant where we worry that by giving immunotherapy, they may go into transplant rejection, or if they have a serious autoimmune disease where the risk of them having a relapse or a flare of their autoimmune disease could be life-threatening. To help us answer that question for not those patients in that population, there was a couple trials, but here in the United States, there was a trial called DreamSeq. And so this trial was really pivotal in helping to answer part of that question. So in that trial, patients with BRAF mutations were enrolled. They've never received any sort of therapy. And so they were randomized, meaning a coin was flipped, and one group, well, I'll call group A, got immunotherapy first. And in this case, it was a combination of two drugs, ipilimumab and nivolumab. And they continued that drug until they had progression. And at the point of progression, they were switched to the targeted therapy. So they got one of the targeted therapies, dabrafenib, trametinib. In group B, they received the opposite sequence. So they were started on dabrafenib and trametinib first, and at the sign of progression, they were switched to the combination immunotherapy. And so what the investigators of the study found was that group A, the group that received the immunotherapy combination first, had a significantly improved survival at 2 years compared to the group that just got targeted therapy first and then immunotherapy. And what that looks like at 2 years was about 72% of the patients that got immunotherapy first, compared to 52%, so 20% improvement for those that got targeted therapy first. So that's sort of answered or settled a little bit of that question. And the bottom line is that most patients that we see, we offer immunotherapy first rather than targeted therapy, despite all the benefits I had mentioned. Now I'm going to shift gears a little bit and sort of talk about, now that you've seen your doctor and they've recommended that you start a BRAF/MEK inhibitor, um, you may be doing well in terms of the tumor responding and you're seeing your scan shrink, but you're probably having some sort of side effects. Like I mentioned, about half of the patients have serious side effects, and then more than half, almost 90% plus, have some sort of side effects that they're dealing with. I'll touch upon a few of these today. So the most common side effects that we see that patients talk about are fever and pyrexia, fatigue. We do see quite a few skin toxicities. We see GI or gastrointestinal side effects, including nausea, vomiting, and diarrhea. And many of our patients complain of joint and muscle pain. There are some rare but serious side effects we also mention to patients when we start these medications. One is called cardiomyopathy, which we'll talk a little bit more, and there's also ocular toxicities. Both these side effects are related to the MEK inhibitors, so in general, we have to monitor for both since we give these in combination. So fever and pyrexia have been one of the more challenging side effects that patients know when they're on these therapies, particularly dabrafenib and trametinib. And it seems to be that the dabrafenib drives a lot of the fever. So we always recommend that patients have a thermometer ready. These symptoms can occur the same day that they start or within a few days. If you do develop a fever, depending on how high it is, we'll recommend that you hold the medication. Oftentimes, that is enough for the fever to abate. In about 24 hours, the fever will probably you'll be fever-free, and then we'll have you talk about whether we should resume the therapy or make some adjustments. At the same time, most patients will recommend starting Tylenol or acetaminophen to help lower the fever, and or ibuprofen to help with that as well. In those cases, typically, we see pretty high fevers, sometimes over 102, even sometimes over 104, where patients start these therapies, Tylenol, they're on the Motrin, but the fevers don't go down, even when they're on it around the clock. And in those cases, sometimes we'll have to start something like a low-dose corticosteroids, typically prednisone, to help get that fever down. So really the goal when you do have fever is to obviously be fever-free. And there are different strategies in terms of how we can manage that. For me, and this is different if you ask different medical oncologists, for me, I try to keep the patient on the highest dose that they can tolerate and try to give them the Tylenol, sometimes around the clock, interspersed with ibuprofen, to keep that fever away as much as possible. And if that doesn't work, oftentimes I'll just go to the prednisone. And the reason for that is, we feel or we think that, being on the highest dose can provide the best results. But at the same time, we can't have patients be miserable and having fevers every day. That's just not, tolerable at all. So in those points, we will talk about a dose reduction. And in some patients, what we've seen is sort of a pattern where they're on the pills and they're doing fine for 4 or 5 days, but then on day 6, the fever hits. They have these significant side effects. That's when we sometimes will tell them to just take a break, be off the medication for 2 or 3 days, and then what ends up happening is that sometimes they're on the medication during the weekdays, and then on the weekends they take a break, and they kind of go through this cycle where they need a drug-free period to kind of continue the medication. And that seems to be a good strategy because, you may not need constant inhibition of that pathway to achieve a benefit. Dr. Gill did an excellent sort of presentation about some of the skin toxicities, and I won't go over it too much, but in combination, I'll just say the BRAF/MEK inhibitors have luckily produced less skin side effects compared to the BRAF inhibitors alone. Historically, what we saw when these drugs were sort of discovered in sequence was that the BRAF inhibitors, patients got tons of side effects. They got new skin cancers. And then when we added the MEK inhibitors, the trials seemed to show that the MEK inhibitors canceled out some of those skin toxicities, which is actually a huge benefit for the patients. And there's a biological reason for that, but basically it shut off one of the pathways that led to more of these skin toxicities. So the most common ones we see, like Dr. Gill mentioned, is sort of an acneiform rash. We also see itchiness, dry skin, photosensitivity and folliculitis. And I think the most important thing is, have your patients or have the patients see their dermatologist sometimes to help manage some of these significant side effects. Also talk a little bit about cardiomyopathy, and what that really means is sort of weakening of the heart muscle so that your heart doesn't pump as good. Some people call this something like heart failure, but what we're seeing is sort of what we call a MEK inhibitor class effect. So it's not the brand of the MEK drug, it's all the MEK inhibitors do this. And so that's why for all of our patients, we recommend getting a baseline echocardiogram to check something called the EF or ejection fraction. And all that is really saying is how well is your heart pumping? And we usually get a number, and anything over 50%, we consider normal. And then when you're going through treatment, we will regularly check your heart for with an echocardiogram, or if you're symptomatic, we'll definitely make sure that we check your echocardiogram to make sure that there's not a drop in the ejection fraction, because that would suggest that the heart is weakening, it's not pumping as well. And when I say symptomatic, typically patients will have symptoms of heart failure like swelling in their legs, shortness of breath. Sometimes they'll have chest pain. Sometimes they may even have changes on their EKG to suggest that their heart is not working as well. This is an uncommon side effect, so luckily we're not seeing this across the board. But, this is something that we want to avoid as much as possible. The good news is that most patients have had resolution after stopping therapy. And oftentimes if a patient has, a history of heart failure or other, things like coronary artery disease or hypertension, we'll send our patients to our cardio-oncologist that will see the patients as well and sort of maximize their heart functions just in case something like this were to happen. Lastly, I want to touch upon a fairly rare, but something I've been seeing a little bit more often in some are sort of ocular toxicities. So essentially, effects on the eye, and this can range quite a bit. So for some of our patients, we recommend either regular visits or if they're symptomatic. I will say it is hard to get into an ophthalmologist, so sometimes we'll have their optometrist see them if there's any serious issues first and try to get them into an ophthalmologist quickly if we can. Most mild side effects include things like dry eyes or conjunctivitis, and we can treat that with just over-the-counter eye drops or topical steroid eye drops as well. Some patients develop something called uveitis, and that can present itself as just kind of pain in the eyes. And if severe, will lead to us having to discontinue the drug and even using not only topical steroids, but oral steroids to kind of calm that inflammation down. Luckily, that's not common, but something that, we have to watch out for as well, because it is a unique side effect that only occurs with the MEK inhibitors. And lastly, I'll talk a little bit about retinopathy. And so, the retina is in the back of the eye. It helps us see things, obviously. And what happens with patients that develop retinopathy is that they can develop a little swelling in that area. And this is a MEK-dependent class effect, meaning the MEK inhibitor is causing these symptoms. And what that might look like to a patient is something like blurry vision. Colors may look different, shadows may appear, and they may have a lot of light sensitivity as well. And so the typical story that I had recently too is that patients will start out on the drug. They'll take 1 or 2 doses. They'll call me back in a panic the next day and say, "Doc, I can't see anymore. Something's going on." Obviously, we're very concerned about it as well. They stop taking the drug, and their vision, usually comes back fairly quickly within half a day or a day or so. We'll get these patients in to see our retina specialist, and they help us to diagnose if the blurry vision is related to the MEK inhibitor itself. What to do next is always sometimes challenging, because what we typically recommend, depending on how serious it is for them to just resume the drug at full dose. And a lot of patients are very resistant against that idea because they don't want to have blurry vision. But For some of our patients, what we've seen is that their body sort of adapts to that, and the retinopathy sort of goes away after they continue the drug. So for some patients, this can resolve spontaneously after stopping the drug for a day or so, and then we're able to continue the MEK inhibitor. So that is actually the conclusion of our talk. There are, the summary of this is that BRAF MEK inhibitors are great drugs. We use them quite a bit. They do have their place in therapy. Immunotherapy is obviously very important, but these new drugs certainly help a lot of our patients. We still typically use immunotherapy first if you have a BRAF mutation, but if you can't get immunotherapy, these are excellent drugs to use. Unlike immunotherapy and their side effects, which Dr. Johnson will get into a little bit more, most of these side effects are sort of unique. The nice thing that I tell patients too is that if they do develop a side effect, because these are pills, they generally can just stop the medication and most of these side effects will kind of go away on their own. Whereas, immunotherapy, the mechanism of those toxicities are different. This allows us to kind of make modifications on the treatment and hopefully get you through the therapy. It's really just sort of finding the sweet spot. So we're kind of at our 10-minute break. So I'm going to let everyone kind of feel free to step away, grab a refreshment, stretch, and we'll get to our Q&A session in about 10 minutes. Oh, that's totally fine. We'll flip it around. Let's go to the Q&A session and then get our 10-minute break in. That makes sense. So I'm just going to welcome all our experts to kind of sit up here and then go from there. Okay. Okay. All right, great. So we've got a lot of good questions. Can you guys hear me? Okay. So we've got a lot of good questions. I'll kind of just go through them in no particular order. So one of the first questions is, I've had stage 4 melanoma. After ipi-nivo, I have residual brain metastases. Are there treatments specific for the brain? And I guess I can start and then we'll just kind of go. So yeah, so we haven't touched upon this and I'm not sure if we'll get into it specifically, but melanoma really does like to travel to the brain. So that's one of those sites that we recommend MRIs of the brain when we first see a patient. And it's always an area that we worry about. When it does get to the brain, there are different treatment options that we often consider. So it does range from surgery. So sometimes the neurosurgeons may need to remove the brain metastases. Sometimes we'll talk about radiation or something called gamma knife to help shrink the melanoma itself. And then as this patient has experienced, some of our systemic therapies, such as immunotherapy, can cross the blood-brain barrier and help to shrink some of these metastases. So I'll start with that. I don't know if Dr. Chandrasekharan have some other thoughts to add.
No, I think that's a great kind of a great summary. Great brain metastases are very difficult to treat, and definitely feel for this patient who's gone through immunotherapy, is now struggling with residual disease. I think a lot of that also kind of these discussions, these are very much discussions. It's not a clear pathway. A lot of it is dependent on location, size of the lesion. Is there swelling associated with it, in terms of what may be the best way to then treat those locally without, or at least trying to minimize the side effects as much as we possibly can. And as we've described, we have a multi-D team here, but we have even more people, including radiation oncologists, neurosurgeons, and our neurologists, if there's long-term side effects that we rely on to help with that kind of treatment planning.
One of the questions we have here, there's actually two questions related to arthritis and joint muscle pain while on various therapies. I can speak briefly to this, but we'll see what our oncologists say as well. Anytime people go on immunotherapy, they are at risk for developing inflammatory arthritis, especially if they already have arthritis. So rheumatoid arthritis, psoriatic arthritis. When you're boosting that immune system, you can also be involving the autoimmune activity against your joints. Oftentimes, I know the oncologists over here will refer patients, I do as well, from dermatology to see rheumatologists. So our rheumatologist colleagues are physicians that specialize in autoimmune joint disease. I do encourage patients, there are a lot of new biologic therapies that work great for these medications, for these conditions, and many of these are still compatible with immunotherapy. So even if you're on immunotherapy for your melanoma treatment, it doesn't mean you can't get these other medications to try to calm down the part of your immune system that's causing this joint disease. I also will say it is important to get it evaluated and treated. A lot of these joint diseases can cause permanent destructive damage of your joints that are not reversible. So do not ignore those symptoms, especially like joint pains and stiffness in the mornings that last for a really long time. It's not just like you use your joints and they get sore. This is like really swollen joints, stiff joints. But yeah, our rheumatologist colleagues are really important in that.
If it's okay, I'll take a few questions about surgery. So we have one question about after surgical excision on the heel of the foot, that the margin said that the lesion extended to one of the peripheral margins and close to the deep margins. So when we're thinking about, the margins I had on my slides for melanoma, 1 centimeter margin, 2 centimeter margin, that is what we call the gross margin or the clinical margin that we use to make sure we obtain a microscopically negative margin. So if you had your melanoma resected and you had, what's considered a close margin, we generally would not recommend any further surgical further surgery for that. However, for patients that have melanoma that does extend to the margin, that we deem a positive margin, I would generally recommend re-excision of the positive margins in those cases. So when we take out these specimens, we tend to try to mark them in ways that we can be very targeted in what would need to be removed. And sometimes there are some limitations to the feasibility of that. But generally speaking, I would say for patients that have a positive margin where more tissue can be removed, that I would recommend that, but that is not recommended just for a close pathologic margin. I'm going to move on to another one if that's okay. So this is a question about a patient who has a father in his 80s who's been diagnosed with melanoma and is scheduled for a lymph node biopsy and issues about pain and recovery at his age. So I would say, it's always with surgery and any of our treatments a risk and benefit analysis. But if his melanoma is a high enough risk melanoma that there's a reasonable chance that it's spread to the lymph nodes, I have many patients in their 80s and older who we do safely get through this procedure with really minimal pain or side effects afterwards. One of the things, though, it is always worth discussing is whether or not the information from that biopsy is going to change what you do. And what I mean by that is usually we're using the sentinel lymph node biopsy, as I said, as a diagnosis procedure rather than a treatment procedure. And if the sentinel lymph nodes are positive, that often determines whether or not we do things like immunotherapy next. If you as a patient or your family member is likely not going to do any additional treatment, regardless of whether or not that sentinel lymph node is positive, that's when you should really consider, is it worth proceeding with the surgery if we're not even going to act on the information? But the short answer to the question is, I do think the pain and recovery should likely be relatively minimal, even for a patient in their 80s.
So, so I have one here about asking about scans. It says, will you please explain when CT scans, MRIs, and PET scans are used or preferred in diagnosis and treatment? And it's a great question because so we're both medical oncologists, even the surgeons to some degree, but mostly our medical oncologist is the one who's going to be ordering a lot of scans. And I think it can be very anxiety provoking. It can also seem financially toxic. It can also just be concerning in terms of, do I really need to get this radiation and what are you doing with that information? So I kind of just to keep it brief is to say, I think there are disease-derived factors, there are patient-derived factors, and probably external factors like cost, et cetera. For disease-derived factors, the brain is one area where MRIs are preferred. The imaging quality of imaging is better in order to kind of detect small burden disease. You're talking 1, 2, 3 millimeter melanoma metastasis that you can see readily on an MRI. In terms of CT scans for the body, neck down, or a PET scan, which is often head to toe or head to at least mid-thigh, there are preferences there depending on site of disease. For limb disease, I prefer PETs. That's not a rule across the board. It is sometimes provider dependent as well in terms of what we think gives the best information. I will say that for patients that are older, have kidney issues, and we are worried about contrast, that is one of the differentiating factors. And should we consider a PET scan versus a conventional CT scans, both of them having CT components. It's just one is dye and one being a contrast. And I think just a final point, they are expensive. Sometimes there are insurance or payer issues, at least here in the United States. I think we have folks joining from other countries virtually. So it's going to depend on where you are, what your institution has, and what's available, and what's really the best way to monitor your disease. And in general, though, this is a long-term game for advanced disease. It's up to 10 years. There is risk of recurrence. Really, we have patients that I think once they kind of cross that long-term mark, we start to maybe take a sigh of breath and say, okay, this maybe we actually did beat this. But until then, we like to keep our patients very close to our chest and keep you guys closely monitored. Do you have other thoughts?
No, I think that's a great explanation and summary of sort of, which scans to get, when to get them. I have a couple quick questions I'll try to get through. So where is the DreamSeq trial information available? So that was just talking about sequencing of targeted therapy and immunotherapy. This question says, this seems to be very important. How can I present this diplomatically to my doctor? So I guess there's two parts of that. The DreamSeq trial information, you could get the publication at the Journal of Clinical Oncology, but actually at Melanoma's website, Dr. Kim Margolin has a really nice explanation of the trial as well, and in sort of easy to understand terms. And then the other part is, how to present this diplomatically to my doctor. That's always kind of a tense question. Maybe your doctor recommended something and you found something else that seems to go the other direction. I mean, it's obviously a personality thing, but I think a physician should never be afraid to be challenged by either medical evidence about what they're doing. And so I do encourage patients, and I have patients that bring things that are new to me all the time, because it's impossible for me to scan every bit of literature to know what's going on. So for me, I think if you're going to have a good relationship with your doctor, they should feel comfortable at least discussing this with you. And there may be a lot of nuances about why they didn't do it or why they did do it. And I think it's a good opportunity to kind of build a closer patient-physician relationship. This next question kind of touches on surgery too as well. I'll just go through it. So Dr. Dan, you talked about neoadjuvant immunotherapy as being the new standard of care. What do you recommend, or how do you find out for a patient if it's right for them? What are some of the factors that you look at?
Yeah, so first things first, they need to be a candidate for immunotherapy and a candidate for surgery for that to be relevant. So there are some patients, we'll talk about this more, we've touched on it already, who because of other medical factors are probably not good candidates for immunotherapy because of the risks. So obviously if a patient wouldn't be a good candidate for immunotherapy after surgery, those same risk factors would be applicable to thinking about immunotherapy before surgery. Patients that, if their disease is in an area where it's not easily removed by surgery, also kind of fall out of the considerations about whether or not they could be considered for this, because it's the prerequisite is that they need to be able to get both immunotherapy and surgery. But in general, this, like I said, is patients, we have the best data for this in patients who have what we call clinically positive lymph nodes, meaning lymph nodes that you could feel or that you can see on scans. I think that the majority of patients that are in that disease setting, and this, again, this could be either at your initial diagnosis, you're found to have lymph nodes, or you were actually previously diagnosed with melanoma and have had what we call a recurrence in your lymph nodes. I do think that most patients that fall into that category and the things that I've already mentioned should be considered for this. That being said, like Dr. Wang was just saying, there are often reasons that we will, think about pursuing one pathway versus another. So it's really just to let you know that this is a treatment option and one that you can discuss and bring up with your providers. Because I do think that this is going to be where we're moving. I do have another question here regarding surgery. So the question is, do you recommend removing all the lymph nodes if the PET scan shows only spreading to stage 2? So just for kind of clarification in how we stage melanoma. So stage 2 disease is actually where you just have it in the tumor itself. If it's stage 3, that's evidence that it's spread to the lymph nodes. We have a very, very complicated way to stage within stage 3, but generally speaking, it's whether or not it's microscopic or clinically positive. So for stage 2 disease, if for the purposes of lymph nodes, I think the question is probably if you have stage 3 disease, but maybe just in one lymph node. So again, traditionally speaking, the recommendation would be for patients that have, again, clinically positive lymph nodes, ones that you can see on scans, even if it's just one lymph node, if that falls within what we call a lymph node basin, so the axilla being an example of that, the standard recommendation would still be to proceed with a surgery where you remove all lymph nodes in that area, either before or after other treatments. That being said, we are, I do think, moving sometimes more towards what we would call targeted lymph node dissections, where we're going in and actually removing lymph nodes in a more targeted fashion based on the imaging ahead of surgery. But I do have to admit that is at this point in time not the standard of care. The standard of care would still be the complete node dissection.
We have a couple questions over here. One question is there a safe way to tan? For instance, does going to a tanning bed prior to going to the beach reduce the likelihood of burning and chance of developing skin cancer? So great question. And the short answer is no, there is not a safe way to tan. You may be a little less likely to get a burn. And we do know that burns are highly associated with your risk of melanoma, but ultimately you're still doing UV damage to your skin. So anytime you're tanning, that is your body's way of saying, woo, I got a little more than I was ready for. And it's trying to build up a response to protect you. But ultimately, that's still UV exposure that you're getting. It's still damage that's happening to your skin. So I never recommend patients go to tanning beds for any reason. I don't recommend they tan ahead of time. Just, try to be careful like the way we talked about. Like I said, don't be afraid of the sun. You can go out there and spend a lot of time outside and just be careful and try not to tan or burn. The other question I have here is the prevalence of melanoma for ages less than 50 increasing like other cancers? In general, when we're looking at epidemiology studies, there's a lot of somewhat controversy. We do see that melanoma incidence is increasing. The good news is deaths from melanoma are really going down due to all of the amazing treatments that we have now. But some of the thoughts, we're not quite sure if this increase in melanoma incidence that we're seeing is related to truly more people getting melanoma, or just that we are doing a much better job about hopefully educating patients, getting them to the doctor so their melanomas are getting caught. The other thing is that a lot of patients who have melanoma are now getting treated with immunotherapy. They're surviving. They're doing great. As I mentioned, some of them get a new melanoma. So some people are our repeat frequent flyers, but our goal is always to just catch these as early as possible and take good care of people.
Do we have some questions? Okay, yeah, why don't we ask the people here? Sure.
So this is a question I get a lot. So, our lymph nodes, they do certainly serve a purpose. They serve many purposes. So people will often say, but don't I need those? And the answer is you do, but you also have hundreds of them throughout your body that are going to do the job that needs to be done from a more global kind of immune system perspective. So I tell patients, if I'm going in there and removing 1, 2, 3 lymph nodes, you're not going to miss them from you have a couple less lymph nodes perspective. The bigger issue is more, what are the side effects of disrupting the lymphatics more locally in that area? And there are, real risks associated with that. But a few lymph nodes, you'll do just fine without.
Can you explain the difference between squamous basal and melanoma?
All right, so we see even more common than melanoma, we see lots and lots and lots of basal cell skin cancers, squamous cell skin cancers. The basic fundamental difference is that the cancer started in a different type of cell in the skin. So like that first picture I showed, melanomas start in those melanocytes that make pigment. The other types of skin cancers start in those other types of skin cells. Basal cells and squamous cells, we often refer to them as quote unquote the good type of skin cancer. It doesn't mean they're well behaved, but they're better behaved than melanoma. They don't tend to spread as much. They do require, I have a lot of patients with melanoma that also get those other types of skin cancers. Our goal is the same with those. We want to catch them early. We want to get them treated. We don't want to give them a chance to spread, even though they're less likely to spread, they can. And so we watch out for those really closely. And any dermatologist doing a skin check for you is looking out for all of those types of skin cancer.
I have a question for Drs. Wang and Dan. Dr. Dan had mentioned neoadjuvant therapy and the indications for that and how there are only certain categories. It sounds to me like we're moving in the direction of more innovative, maybe aggressive use of immunotherapy, especially in those cases where you can't do a complete staging for various reasons. You can't do a wide resection in a particular body part, can't do a lymph node dissection for various reasons. Are there studies in progress now that are examining the use of neoadjuvant therapy much earlier and in those kinds of cases where you can't do a full stage?
Yeah, that's a great question. So part of that question is like, we started with immunotherapy in advanced stages. Should we continue to bring them up earlier and earlier forward? And, when patients either have lower stage melanoma or in the case, like you mentioned, where perhaps we can't do a complete staging. I mean, I'll say there are clinical trials that are looking at what we are deeming sort of high risk stage 2 melanoma. So like Dr. Dan mentioned, stage 2, you don't have any lymph node spread, but they're really thick melanomas. They may be ulcerated. And when we look at historically the survival curve of those patients, they unfortunately do just as poorly as some of our stage 3 patients. Yeah. So there are ongoing trials that are sort of looking at doing sort of neoadjuvant immunotherapy in those patients. We don't have any data yet to support that. I would say on the flip side of doing more and more treatment, and we'll get into more of the toxicities, we have to really be cognizant of sort of the toll that giving immunotherapy gives and whether there is a benefit of giving, all these patients immunotherapy where they may not really benefit and may just end up getting sometimes, lifelong side effects.
Just a short follow-up. If you have a lesion that was not suspected to be, and this is for our dermatologist friend, and it's removed and found to be melanoma, oops, it's not an SK, now what? Are there markers that are you can't measure anymore because the normal pathology for a suspected SK doesn't, you fix the tissue and you can't find the marker anymore? Are there cases where you'd want to measure markers if you knew it was going to be a melanoma?
That's a great question. Actually, no, basically whenever we do a biopsy, whether it's something benign or something malignant, it goes through the same process. It gets put in formalin, it gets fixed, and then that tissue is sectioned. So the good news is that even if we think something's going to be benign, it goes through the same process, and all of the testing that we might do if it's melanoma can be done on that sample regardless. The one thing that I would caution you is sometimes people go to places and they don't get a biopsy, something gets frozen, burned. We do a lot of freezing and burning in dermatology. And so we want to know ahead of time that that spot is either benign or there's certain precancers we freeze and burn. But if anything, if I ever think something has the potential to be a melanoma, it gets biopsied so that we can do those testing later. So good question.
And on that, one of the things that we will see, though, is I spent a lot of time talking about how the depth of the melanoma is really important to determine what we recommend as next steps. So the hope when I get a pathology report, and it's not always the case, and it's certainly not the end of the world when it isn't, but is that the deep margin is negative, meaning that the depth that the biopsy has showed that the melanoma is the true depth of the melanoma. So, if there's an index of suspicion that it might be a melanoma diagnosis, hopefully the dermatologist is trying to make sure they do a deep enough biopsy to get that true depth. That is the one thing that you could lose in the biopsy. But as Dr. Gill said, the other information we need, we can usually gain. And the reality is the literature out there shows that even if we may underestimate that depth, it rarely ever actually changes the management.
I know everyone has a lot of questions. I don't want to take too much time. We'll have another Q&A. I want you to hold on to your questions. I think I'm being told by Anne we're going to take a pause here, but feel free to come up to us afterwards and ask us questions as well. We do want to engage with everyone here. So we're going to take our 10-minute break here, and then we're going to continue on after that, okay? Thank you guys so much. All right, thank you guys for coming back, and for those online, thank you for sticking with us. So our next speaker is Dr. Sanjay Chandrasekaran. He is a medical oncologist here who specializes in ocular melanoma. So he's going to give us an excellent talk about being in the clinic with ocular melanoma. So.
All right, great. I think so. Everybody rested from their break and hydrated and maybe got some coffee. So we're going to shift gears a little bit into something a little different than what we've been talking about. These are my disclosures. So, if you had asked me when I was a fellow, am I going to be interested in ocular melanoma? Is this something that I'm going to be spending my time with patients and research and clinical trials? And I would not have known. This is almost, it's quite rare in a way. And to me, it's a bit of a Waldo story. If you're really curious, he's there. But, it kind of was happenstance in terms of how this came about. But, the eye has melanocytes, believe it or not. And they're actually not just in the front where we think the eyeball is, and that's the colored part. They're actually there throughout almost most of that posterior structure. The ACS, or American Cancer Society, projects there'll be about 100 to 105,000 cases of invasive melanoma across the board this year in the U.S., and 5% of those will be uveal melanoma cases. If we look across the board, though, of all ocular melanomas, which also include melanomas of the orbit, melanomas of the eyelid, or the conjunctiva, then it makes up about 90% of all ocular melanomas. And there's really three structures as a part of the uvea of the eye. There's the choroid, there is the ciliary body. Oh, great, we have a pointer. And an iris. And most of the choroid is really running all the way through around the posterior part of the eye. And that 90% of the uveal cases are coming from the choroid. The challenge here is that these can live hidden. They can hang out in the back. Patients may not notice them. They generally require some kind of a retinal imaging to actually look through the pupil and then scan the back of the eye to detect these lesions. This is a photo of an actual pigmented lesion, uveal melanoma, from one of our world-renowned ophthalmologists. And some symptoms that you can see, and I say possible because in reality, a lot of these are quite non-specific. Blurry vision, distorted vision, maybe just complete loss of vision in one eye, that curtain or shadow effect that we describe, having floaters or flashes, change in the shape or of the pupil, and then the most obvious one is if you have an anterior iris iris melanoma that will actually, in somebody who's very light-eyed, light blue, light green, you might actually see the pigmented lesion on the front. But as I mentioned, iris cases are pretty rare. So what are the risk factors here? So patients always ask, is it that I was in the sun too much? Is it those Cheetos that I ate when I was a kid? Or maybe, you know, I do a lot of machining at home, or maybe it's just the people I choose to socialize with. And Dr. Dr. Gill went through all these risk factors for skin melanoma, and unfortunately or fortunately with uveal, this is really not true. We just don't have great screening risk factors that we can rely on. There are some trends which I'll kind of address. So men greater than women, older age over 60, again, not necessarily, they're really neither here nor there. We don't make decisions based off of this or screening decisions. We do see trends towards folks who have fair-colored skin, lighter eyes, so this really northern European phenotype where we have a slight predominance, but uveal melanoma can actually affect anybody of any kind of ethnic descent. And in terms of genetics, we have kind of well-known syndromes, but they're very rare. So about 2 to 3% of cases associated with inherited genes. The most common one is a protein called BAP1. So the biology of uveal melanoma is really different. Dr. Wang gave this great talk on BRAF-MEK and the V600E and V600K mutations that we see. And these kinds of alterations that fall in the MAPK pathway for skin melanoma do not occur in uveal melanoma. The target genes are quite different, proteins in GNA11 and GNAQ. And that impacts not only how the disease grows, how it spreads, what it does, where it goes, but also the kinds of treatment approaches. With skin melanoma, we talked about lymph nodes extensively. We don't really look in uveal melanoma for lymph nodes. This disease does not move into the lymph node drainage and then to other places. It goes straight into the bloodstream. It's notoriously has that capacity, and the liver is basically a sanctuary site. 90% of distant disease will end up in the liver. And as I mentioned, again, the treatment approaches are quite different. So the genomic landscape of uveal melanoma is really important. It's been an evolving science over the last 10 to 15 years. Our chair of ophthalmology here, Dr. Bill Harbour, and many of his great colleagues have been pioneering this science. Really, it's to understand, and now we do understand, how do you go from just a completely normal pigmented melanocyte in the back of the eye, have mutations that show up in that melanocyte, and then it becomes more and more active over time. It goes from being benign into a low-grade pigmented lesion that maybe you don't have to do anything about, to eventually progressing into a true melanoma that either has higher or lower risk features and higher or lower risk for metastasizing. What we know now is that there are really two major factors that contribute to the risk of spreading disease. So this was published earlier this year. This was an incredible amount of work through an ocular cooperative group, almost 26 different centers that participate, 1,500 uveal melanoma patients that contributed their experiences and their science to developing this data. And what we know is that we can send for gene expression profiling and we get a class, or class 1 or class 2, a low risk versus a high risk. We can also look for the expression of a protein called PRAME. This is very specifically expressed and is is known in uveal melanoma, if expressed, to contribute to its ability to spread. And putting those two together, you can get a curve like this, where you can see a low-risk disease where it's class 1 on expression profiling and not expressing PRAME, to something that is very high risk for spreading within the 5-year period with class 2 or PRAME expression. What we also know through this data and other smaller studies, this is probably one of the largest ones out there. If we look at the prevalence by class or risk, about 50% of the uveal melanomas are on that low risk class 1 PRAME negative, and then the rest fall in the higher risk where they're either class 2 or have PRAME or both. So this is in the focus of the talk. We'll kind of shift gears. We covered a little bit of the biology, but really this is an overview of what it's like to be a patient and how do you move through, who do you see, and who's going to be involved in your care. And as a theme that you've probably commonly seen today, it is multidisciplinary. So when you get that initial diagnosis, you have vision changes, a patient goes in and says, hey, I have blurry vision, an optometrist or maybe an ophthalmologist looks in the eye, a concerning pigmented lesion is seen. You should be referred to an ocular specialist. This is an individual who will be able to do an ultrasound, measure the size of the tumor, and then guide further local therapy management. Local therapy can be in two forms, either through radiation or a surgery through an oculoplastic surgeon. The goal of this is to kill all those cancer cells in the eye so that the disease cannot spread. At the same time, we strongly recommend now getting a biopsy done. The biopsy here is, again, not to prove that it's a uveal melanoma. That is largely a clinical diagnosis. The biopsy is to get that gene expression profiling and PRAME data, because that's what, as I showed in that last curve, affects how do we think about what's the risk of this disease spreading? Where would that patient's disease fall in terms of risk stratification? And based on that information, a medical oncologist like myself would be able to discuss, this is how we want to do scans and surveil for recurrence, or are there any trials that are available that might prevent or seeking to learn how to prevent the disease from spreading? The local treatments are very effective, up to 5 years. Most of these are over 90% effective in preventing a local occurrence. Again, this is in the eye. Radiation oncologists get involved. They work with the ophthalmologist. They place a very small plaque on the tumor. That tumor is then killed off. The plaque is removed, and then patients are monitored. The alternate option, as you can imagine, is a surgery if the tumor is large enough and a plaque cannot be placed. So it is, I did try to find a nice graphic, but they're quite not lunch friendly, so we'll go with Etsy. But you get the point. It would be extensive, and it's not to make light. It truly is a life-altering decision to have to undergo an enucleation. What happens next is largely in my clinic, where I see patients and talk about surveillance monitoring. These are our national guidelines. I'm highlighting basically that we think about things now through risk stratification. How often do you need to do scans based on the risk of something showing up, which is based on the biology of that patient's particular tumor? Some general comments to this, as we have folks from here locally, but also just multiple other centers and also folks from around the globe that are listening in, is that as far as the science goes, there are no known approved or truly effective adjuvant therapies that are broadly endorsed. This means that after you've had your primary treatment to the eye, that you should do 1 or 2 or 3 years of some kind of treatment. That does not exist at this time. Work is being done, but it doesn't exist. Liver imaging is a top priority, as 90% of the disease will show up, or metastases show up in the liver. The type of scan used is going to depend on a lot of things. It depends on the provider preference, the country that you're in, how much it costs, what are the resources to get that type of scan, or even just the treatment center where you are and their preferences or their technical expertise. So effectively, something should be done, and it should be done longitudinally. It shouldn't be a one and done. And this is because, kind of reiterating that curve, there are folks who have at the 6, 7, 8 year mark late recurrences of disease. So we don't want to just do 1 or 2 years of surveillance and then let patients go. The approach to treatment, and I'll just go in as an overview. I don't talk about side effects because that would take another 40 minutes and then we would be into lunch. But effectively, there are different modalities that are available. So the liver-focused or directed options, we have approved agents in this space, and we have also clinical trials that are exploring further options here. There are immunotherapies, which we've talked about. We have approved agents, largely pulled from skin melanoma, other clinical trials, and then also looking at the HLA status of a patient to determine which kind of immunotherapies are best. There are cellular therapy options. We'll talk, it comes from skin melanoma, but we've adopted some of that over to uveal and other further clinical trials in that space. Targeted therapies, a little bit different than the BRAF and MEK inhibitors that Dr. Wang had talked about, still in clinical trial phase, and then less often used, but often still brought up as a consideration are more conventional chemotherapies. So if we think a little bit about the liver-focused or directed treatments, you can really put these in sort of two groups. You have the ablative approaches, so if there's a single site of involvement, maybe you can just cut that out or ablate that single site or use something like external beam radiation to treat that site. When the involvement of the disease is more multifocal or larger and you cannot completely treat that area or resect it, we use embolic and non-embolic approaches. This is using the vascular structure of the liver. The liver is basically a filter for your body, everything kind of moving through there. So it's a unique way and a very liver-specific way to be able to put a catheter into the liver and then treat using the vascular structure. And the embolic approaches are either to push chemo into one of the branch stems of the liver. You can also do immunotherapy agents or beads, radiotherapy beads. And then the one that has been adopted and has become more, was recently approved in the US in the last 2 years, is a perfusion-based approach. And we'll specifically kind of talk about PHP or percutaneous hepatic perfusion. So this is an FDA-approved treatment here in the U.S. now, and what it is involved to a degree. The liver vascular supply is isolated in an operating room with a whole team of anesthesiologists and possibly a surgeon or a radiologist, and chemotherapy is infused directly into the liver. You're basically bathing the entire liver vasculature with this chemo, melphalan. That chemo, then whatever is not kept in the liver is then captured on the way back out. And these patients are then monitored afterwards for, just because of the risk and the vascular cannulation side effects and other things related to this treatment. But it is a very much so, I think, a full-on liver-directed approach. There are some approaches in trials as well. This is just one example. It's called SD101. It is actually a combination of a device and an immunotherapy. They're targeting a mechanistic pathway called the toll-like receptor 9 pathway to drive immune cells to come into the liver and start working against the melanoma. And it even fights some of the cells that are inhibiting that within the tumor environment. And again, it's in trials, so it's not something commercially available, but I think always exciting to know that the science is looking for new things. In terms of immunotherapies, we have approved agents in clinical trials. In terms of conventional checkpoint inhibitors, Dr. Wang had touched upon ipilimumab, nivolumab. There are other classes of other available checkpoint inhibitors. It comes down to the uveal biology. It's just different. It just doesn't respond to these immunotherapy inhibitors or as skin melanoma does. Multiple reasons for that. These are probably kind of the low-hanging fruit. The mutation burden, the mutation pattern is different in uveal melanoma. It doesn't express as much of that PD-L1 target for these drugs. And probably the biggest thing of all is the liver is liver sanctuary site. The liver is intended to not be inflammatory. You don't want a bunch of immune cells going into your liver and affecting the liver function. And in a way, it creates a space for these tumors to hang out and to grow unchecked. The biggest kind of first-line treatment that we have, and it's a very important point, is there is a drug called tebentafusp or Kimmtrak by branding that was proven to improve overall survival in patients with metastatic uveal melanoma that express HLA-A0201. A big point here is this is not the tumor that expresses this HLA phenotype. This HLA is a barcoding that makes all humans unique. The company in development had to pick the one that was most common in the most common broadly applicable population. So we see this HLA phenotype in about 40% of Caucasians. The way this drug works is it's basically pulling an immune cell next to the cancer cell through a particular protein linker called GP100. And it is a drug that has to be dosed almost on a weekly basis in order to have that effect. It did show a positive survival benefit. As you can tell, the curve still does have quite a drop, so it's not a wonder drug, but it is one of the best tools that we have for improving survival for patients with uveal melanoma that's metastatic and express the HLA-A0201 phenotype. While the study did not look at comparing it to two immunotherapies at the same time, when we do cross-trial comparisons, which we don't like to do, but if that's the best thing we have, we do, it still seems to be that tebentafusp is preferred over conventional immunotherapy to start with. And so this still remains the standard for those patients with the HLA expression. There are also immunotherapy options that are in trials. So this is with a drug called RP2. This is a herpes virus. The company took a virus. They found out which strain was really good at killing cancer cells and could also activate the immune system, then continued to engineer that virus and make it even more and more potent. The virus has to be injected into the tumor site. And the early trial data is showing that it not only helps the tumor site where it's injected, but also creating this immune response to shrink tumors, as you can see, like in the yellow circles, outside of where the drug is injected. And it's given with conventional immunotherapy. It still is in trials, and it's something that many centers, including ours, will be offering for patients. In terms of cellular therapies, this is shifting quite a bit in terms of the delivery and the entire process. Many of you who are, and most of the uveal patients are highly informed. They always ask me about TILs. What about TILs? Can I do this? TILs are basically this process where you are going in, cutting out tumor, extracting the immune cells that have found their way into that tumor, but they just need more of them and more help to fight the cancer that they're surrounded by. And so the tumor is cut out by a surgeon like Dr. Dan. They're sent off to a company. The company, this is for the commercially available product in skin cancer, but we can sometimes get that coverage here in the US for uveal melanoma. Gets sent off to the company. The T cells are then taken out of the tumor. They're expanded over a period of weeks, frozen, and shipped back. And then we put them back into the patient. It's quite an involved process. The responses here as well are not as good as we've seen historically with skin cancer, but there are trials now to understand maybe is it the type of cells, is it the cocktail of how we're expanding the cells, trying to improve on this process. Finally, talking about targeted therapies, which will be the last one I'll really focus on, and the clinical trials here. As we mentioned, the uveal biology is different, so it doesn't use BRAF as that driving force, but many uveal melanomas will express amplifications in GNAQ and GNA11 related pathways. And so there are drugs now that target PKC and c-Met to inhibit that driving process. So this is in trials with a combination of darovasertib and crizotinib, looking at the effect of that in HLA negative patients versus more conventional treatment options. And so it remains in trial phase, but it still is an option to consider. In terms of what else can we do? So a lot of patients just feel like, hey, I got this diagnosis, I had my local treatment, you're telling me I'm class 2, I'm praying positive on the tumor. I just feel like I'm just waiting. I'm watching and waiting for that scary day to come. And we're developing options. Dr. Wang had mentioned ctDNA as well. Uveal biology being different than skin, there's other ways to target the circulating tumor DNA. This is some data that was publicly available that was done by a company. It's it's not a commercially available ctDNA test, but it was specifically created for use on the tebentafusp trial, trying to understand which patients really benefit from tebentafusp. And we do see that those that had reductions in the ctDNA actually did better. Those are the patients that even if tumor wasn't shrinking on scans, they were responding in terms of the survival benefit. And we have research here as well to further build out ctDNA technology, specifically in uveal melanoma with the Harbor Lab. So putting this all together, and it's a lot, it's a full, it's really a multidisciplinary experience with a lot of providers and a lot of time. And we start with the local therapy. You see a provider, you determine, should I do radiotherapy? Should I have a surgery? Can I get the biopsy? I didn't touch upon this, but we also consider, if available, neoadjuvant trials where you're doing treatment before that plaque or that surgery happens to either shrink the tumors or try to improve vision outcomes, and particularly in patients getting plaque. After that happens, you move towards a risk-adjusted approach for surveillance, looking at the GEP and PRAME, information from the tumor, and it's really a multi-year long game. We can consider adjuvant trials if something is available in that setting. And ultimately, whether you do a trial or whether you're just on surveillance, you are looking then for, at the time of progression, what do I do next? So based on the location of the disease, is it liver only? Is it outside of the liver? What is the patient's HLA status? You make decisions. Should we do tebentafusp? Should we consider a clinical trial? Or should we consider a liver-directed approach? While we would love any one of these initial therapies to be it, that's the cure, where the science is right now, nothing in the first line is a cure for this. Patients, ultimately, we have to think, this is a patch, the next thing is coming, what is it gonna be? A lot of this is in my clinic is talking about opportunity and creating opportunity for next line treatments. It's not about finding the one treatment to end the whole story, but to actually find how do we keep things going. A lot of this depends on what are trial criteria. Sometimes you can do liver directed up front, or sometimes you can't because the trial that may be coming online excludes the option of patients who've already had liver directed. So there is sequencing here that's very much driving how to create opportunity and find the treatment that ultimately may work for someone. So our team is quite multidisciplinary. We have our ophthalmology team. Dr. Harbour leads this program. He is our chair of ophthalmology, a world-renowned ocular oncologist, and he's my mentor. Very, very fortunate to be able to work with an individual like himself. Dr. Margaret Lang-French is one of the ophthalmologists, also sees these patients, does the biopsies, and then refers over to us. We have our local therapy team with Dr. Mike Topolsky in radiation oncology and Drs. Tenzel and Mancini, who are oculoplastic surgeons if an enucleation is something that needs to be discussed. We have Dr. Kim in our interventional and vascular team to be able to do these biopsies. Most of these times we always try to confirm the liver disease by biopsy before we make plans to do anything. Dr. Kim also is involved with the hepatic-directed or liver-directed therapy programs that we have. And really, this team, we have built this and to really focus on caring for patients in the DFW metro, but also to reach beyond North Texas. We have a growing trial portfolio, and we have a lot of really interesting multidisciplinary translational research projects across all of these specialties going on at UT Southwestern, and just a wonderful team of external collaborators. So I'll say thanks. This is Dr. Harbour pioneered this cooperative oncology group. Uveal melanoma is a small space. So the providers that care for this, the providers that know about the trials and are engaging with companies that are developing new strategies, it's a small group of folks. And we try to meet often and collaborate. And we love sharing patients and saying, hey, I have a patient that maybe would be better suited to come see you for a trial that you have. Of course, thanks to all the patients that trust us and give us the opportunity to care for them. And I think with that, hand it back to Dr. Wayne.
Well, thank you, Dr. Chandrasekharan. That was an excellent talk on ocular melanoma. It's honestly one of the new frontiers for melanoma. We've had so much success with cutaneous melanoma, and so a lot of the approaches in ocular melanoma may be pivotal for other, cutaneous and other types of cancers. So we're gonna shift gears to our virtual presenter. So this is Dr. Doug Johnson, who's coming virtually from Vanderbilt University. He's actually my mentor. I trained with him during fellowship, and he really got me involved into melanoma. And we're really happy to have him here. He is the director of the melanoma service at Vanderbilt, but he also is the co-chair of the NCCN guidelines for cutaneous melanoma. So he helps to guide us in terms of what we do across the country and sometimes across the world. And he's going to give us a talk on his expertise, which is immunotherapy toxicity. So we'll go from there. Thank you.
So thanks, Dr. Wang. It's a real pleasure to be here. Please let me know if there's any audiovisual issues, but really nice to be with you all today. I'm sorry I couldn't be there in person. So I'd like to talk a little bit about immunotherapy toxicities. And before I do that, I'll just kind of level set with a couple slides about immunotherapy and why it's been transformative and why people are excited about it. Again, many of you are probably familiar with these kind of concepts, but I think it's always good to take a step back and think about the big picture quickly. So in terms of immunotherapy, it's been in the news a lot in the last decade or so. Certainly Jimmy Carter, the former president who just recently died of something besides melanoma, just over 100 of other conditions, received it over 10 years ago with a really durable long-term response. Of course, it's very difficult to get away from the advertisements. Can everyone hear me, Dan?
Yeah, you're good. I'll be driving it, so I'll follow you, and I'll drive the slides for you.
Oh, really? So I tried to share my screen.
I can see your slides, and then I will just go along with where you're at.
Oh, I see. Okay. Well, sorry about that. Let me know if I need to do anything. It's very hard to get away from some of the ever-present commercials for pembrolizumab or nivolumab or others. And then, of course, as many of you may know, the Nobel Prize was shared by Jim Allison and Tasako Hanju for basically discovering the molecules that were associated with the PD-1 and CTLA-4 drugs. So just to show you how these drugs work, again, many of you may be familiar with this, but just to kind of take a step back and look at the big picture. So T cells are really kind of some of the attack cells of our immune system. And in many tumors, they actually recognize the cancer as foreign, as something to be gotten rid of. But cancer has this one last-ditch effort that it's able to shield itself. And that molecule is a molecule called PD-L1. And basically, when it binds to this other molecule in the T cell, it shuts it down. And so by blocking PD-1 or PD-L1, you're then able to take that shield down and attack the tumor cell with the T cell, and that results in the tumor cell dying and the T cell being activated. Okay, so sorry, Dan, that was some complex animations to follow, so I apologize there. But the upshot there is that the immune therapy can be leveraged. The T cells, our own body's immune system, can be leveraged to attack the cancer cell and get rid of it. Now, the complications I'll tell you in a minute is sometimes the tumor cell can be replaced by an organ cell, for example. So the PD-1, PD-L1 interaction can oftentimes block harmful inflammation too. And so you're kind of having a double-edged sword a little bit when you block this interaction, where hopefully the main effects are positive in terms of getting rid of the cancer, but there also can be inflammation by attacking the organ. But let's start with a little bit more good news first. So Dr. Wang briefly mentioned this earlier, but the reason we use immune therapies is in melanoma is because they really have by far better success rates than some of our conventional therapies that we used to use in melanoma. So this is, if you look down here at the months, you can see this is basically 10-year follow-up from one of our landmark phase 3 studies that basically looked at 2 immune therapies together, nivolumab and ipilimumab, compared to just either one alone. And what you can possibly see here is that these are the patients that are still alive and that did not die from melanoma. Of course, when you're talking 10 years, of course, there can be other things that can cause death for folks, especially that were maybe a little older when they started the trial. But what you can see here is over half of patients were still alive and were really effectively cured from their cancer. And this is true for the combination especially, but also even the single drug nivolumab or another one called pembrolizumab that we commonly use really produces these very long-term responses. And that's very, very different from some of the other conventional therapies that we've used for cancer, not just melanoma, where maybe you would cause the tumors to shrink, but then they would usually come back and cause someone to eventually die, especially when there was metastatic cancer. And the other thing that's important is that these drugs thankfully work in a wider section of cancers than many other kind of cancer therapies. So this is, of course, melanoma we're talking about, where the single anti-PD-1 drugs can cause 45% or so of responses, most of them long-term, but you can kind of see there's a pretty wide swath of different cancers, including some of the very most common and deadly cancers that we can treat with immune checkpoint inhibitors. And so this is a really kind of a new cornerstone and class of treatment that we use for our patients. The other positive for immune checkpoint inhibitors, and I'll certainly talk about the exceptions to this in a moment, is that we used to think about something like chemotherapy as something like a shotgun, where you basically are kind of just blowing away anything that's rapidly dividing and changing. And so you would end up having side effects in the bone marrow and with hair loss, with GI toxicities like nausea and vomiting, and just really patients would feel pretty bad oftentimes on chemotherapy. Not always, thankfully, but it was a pretty toxic treatment, certainly, especially in the old days before we had better supportive measures. But immunotherapy, at least in many cases, can work a little more like a scalpel, where it hopefully attacks the tumor and spares the normal tissues. And that certainly is not always the case, but certainly on a day-to-day level, it's often much better tolerated for folks. And so you can kind of look at this as a glass half full or a glass half empty. I mean, certainly the advances for immunotherapy have been really transformative for a number of patients, where you can have these durable responses, where you can have activity across a number of cancers like melanoma, where we didn't used to have really good options, and where you can have at least a better safety profile than some of our traditional treatments. But of course, there is some downsides, of course, and we certainly need to raise the bar even further. Obviously, having more than 50% of folks alive at 10 years is great, but we would certainly like to have that number much, much higher and do better. And certainly, we'd also like to deal with the side effects. So let's talk about that quickly. And to do that, I'll talk about a couple of cases. So the first was a 60-year-old man who had widespread melanoma that I treated in my clinic. And he actually had this large metastasis in his heart and a softball-sized mass in the lower part of his lung, where you can see that on the PET scan here in the bottom, the right side of his lung had this softball-sized mass. And then just 3 months into treatment, you might be able to appreciate that big glowing mass is now down to this small thing. It's a little bit of an apples to orange comparison because you've got a PET versus a CT, but you can clearly see that mass has dramatically shrunk. And the patient's heart mass had basically melted away after just 2 weeks. The patient had an early echocardiogram where it went away. And so this is wonderful. The tumor is basically melting away because of our immune system. Well, what happens if there is an effect in the organs instead of the tumor? What happens if the immune system is unleashed against the organs? And thankfully, that doesn't happen often, but unfortunately, it does occasionally happen. And so this was a fairly similar case in terms of just demographics. It was a woman, but also about 60 years old, had also pretty widespread metastases, and she was also started on the same treatment. And she came in about a week and a half into therapy and was having some shortness of breath. And there's some of her lab work suggested that there was some heart damage. And this is an EKG, which probably not a lot of cardiologists in the group, but you might be able to, if you imagine, and trust me from what I'm saying here on the bottom here, there are these small little valleys here, and they're really not even associated with some of these other activity. And this is what this basically means, is that the small parts of the heart, the atria, are beating kind of completely separate from the ventricles, which are the big part of the heart. And this is something called complete heart block. And the patient, despite aggressive treatment, deteriorated, and this rhythm came up, which is something called a sine wave EKG, which is really incompatible with life. And unfortunately, this patient had something called myocarditis, which is inflammation of the heart that was brought on by the immune therapy. So let's talk a little bit about side effects from immune therapy. And so unfortunately, these can affect essentially every organ system, thankfully, much less dramatically than this patient in most cases. So some of the common side effects include inflammation of the thyroid, the lung, the liver, the colon, the joints, and the skin. But unfortunately, like I said, they can basically affect almost every organ system, thankfully at lower rates. So what's going on here? So again, as I mentioned earlier, the goal here is that we activate the T cells against the cancer cells, kill them, get rid of them. But unfortunately, sometimes the T cells can be activated against the organs. And so when we use more aggressive combinations, the positives are that that can affect the T cells even more strongly against the cancer cells. But the negatives can be they can also affect the organs more strongly and more severely as well. So what do we do if we get a side effect from checkpoint inhibitors? How do we treat the patient? So I kind of think about this kind of like treating a fire. So if you think about it, there's really three ways we treat it. So first would be we kind of hold off on treatment. Certainly, if there's a more severe side effect, we need to at least stop feeding the fire. We need to remove the source of the inflammation. But unfortunately, that doesn't often completely help because the immune therapy for both positive and negative, it hangs around in our system a long time. And again, that can be very helpful from the standpoint of getting rid of the tumor. But if there is a side effect, just holding the drug, the side effects aren't going to necessarily get better. So really what you have to do is attack the source of the inflammation and really try to mitigate the inflammation with something like steroids, something like prednisone that can really sort of attack the inflammation at the source. And then of course we also need to make sure to support folks while they're dealing with the side effects. So if they have inflammation of the lungs, we may need to give them oxygen. If they have inflammation of the thyroid, we may need to replace the thyroid hormone. And so we've done a lot of studies to try to understand what's going on in the patients when they're having side effects. So this is back to that first patient, or actually case number 2, the one with the heart inflammation. And so normally heart tissue should kind of look like what's going on. If you look at the left picture here, normally heart muscle should look like these sort of pink strips here in the top and the bottom and the corners. But instead, with this patient, when we had a sample of the patient's heart, you could see all these blue dots, which are basically the immune system, the immune cells that are attacking the heart and really basically killing the heart cells. And then it's really actually striking how organ specific it is. So this was from the patient's esophagus, where this was from an autopsy. Unfortunately, the patient didn't survive this inflammation, where we can see the smooth muscle in the esophagus, if you trust me, in the black arrow has really no inflammation, but the skeletal muscle in the skeletal muscle of the esophagus was really just obliterated and inflamed. So what this basically means, and we looked at basically all the other organs as well and really found no inflammation. So this was just a really very specific inflammation to the muscles and really none of the rest of the body. So this is a study Dr. Wang looked at. We were really struck by how severe these side effects were in these very rare cases. So we wanted to look and understand how often these side effects can be so bad that they can actually cause fatalities. And so thankfully we found this was very uncommon. So if you look at patients just treated on one drug, like the Opdivo, like nivolumab or pembrolizumab, you have it about 1 out of 300 patients. And when you look at it in combination, while combination causes better long-term survival, it also causes more severe side effects, about 1 out of 80 patients. And the heart issues you can see in this where it says myocarditis, in terms of how likely it was to cause fatalities, was certainly the most dangerous. But other side effects like lung inflammation, pneumonitis, can also cause fatalities as well. So this is something that we really, I think, goes to show that we need to be very vigilant and monitor patients that are on treatment and deal with side effects quickly. What was also striking to us is that we looked when patients were treated the very severe side effects often happen very early. So this was looking at time to onset of these more fatal toxicities. When you're looking at folks treated with combination, it was very early, like 2 weeks into treatment was when their fatal toxicity started. So that's why, at least in our practice, and again, everybody's got a slightly different practice, we tend to get weekly labs at the beginning of treatment just to make sure that there's no sort of very severe side effects that are coming up early. Although, again, that's a little bit controversial and everyone kind of has their own opinion about how often to monitor. Now, thankfully, steroids work for most kinds of side effects, but as you can see from that fatal toxicity slides, we really need better treatments for some of the most severe side effects. And this was a study from Dr. Salem, who's now in France. He was a cardio-oncology fellow at Vanderbilt for a couple of years. And he was noticing that despite really aggressive treatments on the left side of the slide, that patients who were developing this heart inflammation and muscle inflammation had a very high fatality rate. 6 out of the first 10 patients that came on his unit unfortunately died of the inflammation. But when he pioneered this new treatment of something called abatacept, which is kind of like the reverse of ipilimumab, one of the other drugs we've talked about, and another drug called ruxolitinib, he had out of his next, I think, 26 patients, only 1 died from the side effects. And so we're really trying to figure out what are these innovative treatments that we can do when steroids don't work, or when we know that there's a low chance or a high chance of them failing. The other thing I'll briefly mention is we're also realizing that side effects that are more lingering and more chronic are also an issue. Again, thankfully, not terribly severe in most cases, but potentially up to about 40% of folks that have had immune therapy. And in fact, if there's some folks in the audience, hopefully that you didn't necessarily have any of these, but you may have experienced some. And so one of the more common ones that we see are low thyroid. Of these more long-lasting side effects, low thyroid was certainly the most common. We also see a lot of low adrenal function or low pituitary function, but there's also other ones like arthritis and rash. And so we've got several large studies to try to understand what the impact of this and what perhaps better treatments might be to prevent them or treat them if they do come up. And so this is something we've got a couple of grants pending, and we'll see what happens to grants overall at the moment. One other thing that we've really spent a lot of time thinking about is Dr. Wang mentioned, thinking about what are the right patients for treatment and when should we withhold treatment because it may be too dangerous. And one of those situations that was very complicated, especially when these drugs were first getting approved, was patients that have autoimmune disorders. So things like Crohn's disease or rheumatoid arthritis. Those patients already have an immune system that's a little bit, you can think of it as overactive or perhaps active in the wrong way. And so we would worry that we might be pouring gas on the fire if we gave immune therapy to these folks. And so what we found, and we and a bunch of other folks have studied this, is that we found that actually this tends to be pretty safe in most patients, thankfully. A lot of times the autoimmune disease will flare. So if somebody has rheumatoid arthritis and we give them immune therapy, oftentimes the rheumatoid will flare a bit, but usually just some fairly mild treatment like low dose prednisone will make it very manageable. And so this is something we now fairly routinely do, and it's very, very, it really opens up the treatment options for some of these patients. So we think about these patients with caution, and there may be some exceptions. Like we have a paper that's about to come out that looks at patients that have myasthenia gravis, which is a autoimmune disease that affects the nerves and muscles. And that seems to be quite dangerous. In fact, about 2/3 of patients had flares, and many of them were life-threatening. So there may be some occasional exceptions to this, but in most of the time, we can safely treat patients. This is something I've been talking about side effects and how sometimes they can be severe. And so this is something we give our patients is basically a card for their wallet. This is showing the front and the back. So this is kind of making sure that folks have a reminder of what some of the side effects they should be monitoring for. And then it also has the back side is for healthcare providers. So if somebody comes into an ER that's maybe outside of their treating institution, if maybe they live a couple hours away and they end up in a local ER and the doctor doesn't have any records and really is not quite sure what treatment they're on, this kind of has information for them so that they don't just say, think the patient has diarrhea from chemotherapy and give them some fluids and send them home. Instead, they probably need some steroids, or at least to get in touch with the clinic that's treating them. This is a couple other just briefly in terms of lifestyle. These are questions that I often get about what should we do if we're on immune therapy, and so these are the things that I tell my patients. Again, these are things that don't necessarily have huge studies to support it, but certainly based on my and others' experience, we generally recommend people maintain their activity. There's no real obvious restrictions. Whatever folks were able to do beforehand, they should hopefully be able to continue. That may be not true all the time if somebody has a side effect, but certainly our goal would be to continue activity. There's been a couple studies that suggest that high fiber diet and fish oil may help the immune therapy work better. There's still a lot to work out with how diet affects the immune therapy, but it seems like some of these treatments, these dietary things can shape our microbiome, the bacteria in our intestines, in a way that helps train our immune system to attack the cancer. So it's quite complicated. There's probably way too much going on than I can understand, or any of us can really understand. But that certainly seems to be the case, that the right kind of bacteria in our gut can really shape our immune system in a favorable way against the cancer. And then finally, folks are not immunocompromised when they're on immune therapy. That can occasionally be not the case if they have to have steroids or something else to calm the immune system down. But generally speaking, you don't have to, be super worried about getting a cold or something like that. Obviously, try to avoid a cold, but it's the kind of thing where you don't have to be as worried about as somebody, say, with a stem cell transplant or on high dose chemotherapy. So with that, thanks again to Dan and to many other folks that have supported my work. And I'd be happy to take questions during the question period. Thanks so much.
All right, thank you, Dr. Johnson. That was an excellent talk. We will try to move on to our Q&A session and see if we can get Dr. Johnson involved somehow too as well. Oh, I am sorry. I'm doing everything out of order today. So now we have Ann Taylor Garst here. She's going to be telling us a little bit about some of the initiatives at AIM at Melanoma. Thanks.
Hi, everyone. Let's see if I can, there we go. Can you hear me a little better? I know that you're anxious to get to the Q&A session, and there were a lot of questions in the room, and we've had quite a few from our online guests. But if you will, I'd like to spend just a few minutes telling you about AIM and Melanoma, because we are your patient advocate. Our organization was founded 20 years by Val Guild. 20 years ago, her daughter, Charlie, was diagnosed with melanoma at the age of 25. There was only one FDA-approved treatment at that time called IL-2, and Charlie didn't respond to it. So when Charlie passed away, Val founded AIM at Melanoma with two purposes. The first was to find a cure for melanoma. So she founded the International Melanoma Working Group so she could get researchers from all across the world together on it. Thank you. I'm a person. Those of you who've met me, I'm a people person, not a technical person, so they have to help me out here. Get me on doing the right thing. Okay. Anyway, okay, here we are, AIM at Melanoma. So she wanted, first and foremost, of course, to find a cure for melanoma in our lifetime, hopefully. And she founded the International Melanoma Working Group, where she gets researchers from across the world together to talk about their research, to collaborate with one another. And also, she established 5 tissue banks where we collect fresh, frozen primary tissue, and we're almost ready after these many years to start distributing that tissue to the researchers, because they told us that it's this tissue that may lead to some, the most promising treatments. So we just want you to know that, so that you will know that we are part of that positive force in the world that hopefully is moving to a time where we have 100% response to treatment. Let's hope that we get there very soon. The second thing that Val wanted so much for people who are living with melanoma is to have a resource that they can count on to give them reliable, up-to-date information, so that you don't have to go to Dr. Google and get, information that doesn't necessarily, one website says one thing and one another. So we wanted you to have one-stop shopping. So here we go. Let's see if I can do this. Yay. There's our website. So there's some things on our website I want to make sure that you know is available to you. Anything that I talked to you about today, all of these resources are available to you, of course, at no cost. So the first is, we know that by far the most frequently visited web pages have to do with staging, their related treatment, and side effect management. Also, we have a section of our website that is dedicated to clinical trials. We have a clinical trial matching service. And we even have a section that we've just added this year on TIL therapy, which we were talking about earlier. We have a service called Ask a Medical Expert. Melissa Wilson is a PA that works in medical oncology. She's not there to change your plan of care. She's there to help you to understand it. We all know that we have limited time with our wonderful physicians, and also sometimes we're only recording a little bit while they're talking to us. And later on when we go home, we'd say, well, what did she say? What did he say? And so you can reach out to Melissa and write to her, and she will make sure that you understand what it is that your care team plans to do and how they plan to take care of you. Because she has gotten so many questions from the public, she started a webinar series called From the Clinic to the Living Room. So some of these same questions that kept coming to her again and again, she made webinars on them. We want you to come to our website and watch some of these webinars. We have 10 melanoma symposiums a year, just like this one. And here's what happens with the recording that happens. We've been recording. I've been, kind of like the Wizard of Oz over there behind the curtain. And so what we'll do is immediately following this symposium, about 20 minutes later, this symposium in its entirety will be available on our YouTube channel. And if you don't know how to go on YouTube and look up AIM at Melanoma and subscribe, come to me and I'll teach you how to do that. But we want you to know about all of our symposiums and all of our webinars. So this entire symposium will be available to you to watch again. In addition to that, we will take each one of the presentations, we'll divide it by topic, edit it, and we'll put it back on the same web page that we have out to the public so that our virtual viewers today, so that they could watch, you can come on to AIM at Melanoma's website and watch an individual presentation if you'd like to see it again, or if you'd like to share it with your friends or family. We have a podcast that's called Beyond the Clinic. The focus of our podcast is about the emotional impact of being diagnosed with cancer, the anxiety that you can feel, the isolation that you can feel. And we want to, give you some helpful hints and some encouragement. Our podcast host name is Dr. Sam Siegel, and she is the Director of Cancer Survivorship for KP in San Francisco, so I invite you to come and listen to some of those podcasts with us. We have a section on caregiving. We know that melanoma impacts not only the patient, but everyone who loves them. Whether you're married to them, just your father or your mother, whomever it is. We encourage you to come there and learn how to take care of not only the person that you love, but yourself as well. And finally, I want to tell you about Peer Connect. Peer Connect is a volunteer program. We have over 60 people across the country who have completed their melanoma journey, and now they want to give back. And so what they've done is gone through a training session, and they're available to be a source of inspiration and encouragement to people who are still going through their melanoma journey. So if you would like to have a mentor, then you can reach out to Ann, and Ann will help you get connected. I want to take just a minute to tell you that here in the Dallas area on May the 3rd, we're going to have a Steps Against Melanoma walk. The reason that we have these is because 100% of the money that we raise through these walks goes towards funding our tissue banks and hopefully finding a cure for melanoma. And you don't have to, we need to raise the money, but you don't have to pay to come and walk with us, because the other thing that we want to do is we want to raise awareness about sun safety. So you can come and raise money to cure melanoma, and you can come and raise awareness about sun safety, and that's a win-win for everyone. Lastly, we have a huge website. I'm your navigator. So if you would like to reach out to me, I'm Ann at AIM at Melanoma. I'll help you find anything that you need on our website. And then I have included a survey if you are viewing with us virtually. Thank you for joining us, and a survey will be sent to you as soon as at the conclusion of the symposium. And inside of your packets today is a survey. If you'll complete that, that'll make sure that we present the information that you want to have it at future symposiums. And with that, I cannot leave the stage without thanking UT Southwestern, Dr. Wang, for serving as our moderator and our panelists for their collected wisdom, and all of you for joining us today. And now, our last Q&A session.
Yeah, I was going to say, I think we'll go ahead and get started with any questions of any participants in the audience.
By the way, y'all did a great job today. I'm just kind of interested in what's going on here at UT Southwestern with clinical trials and how we can give back with those as well.
I can start a little bit and talk about some of our, interventional clinical trials. Like Dr. Chandrasekharan was talking about, he is leading sort of the uveal melanoma charge, and there are several clinical trials in that space that he's opened up. On the cutaneous side, we do have some specific trials that you can look up at UT Southwestern's website, but more specifically, we have trials looking at using newer therapies like oncolytic viruses that we can inject into the melanoma, combining that with immunotherapy. And I think, clinical trials are definitely an opportunity for not only patients, but for the community to be involved in sort of advancing the care. And so we're continuing to sort of open up new trials, and we as a group certainly try to screen patients for trials, but we do encourage patients to also bring trials that may not be open at UT Southwestern if they're interested in talking about those, so that we can provide opportunities, for these patients.
I was just going to add one thing too, that there's lots of different types of clinical trials. So some clinical trials, have the goal of providing an intervention and a treatment that provides patients with new treatments that aren't yet currently available. But there's also other clinical trials that are partly more educational for the research community. So, a lot of the work that we do here at UT Southwestern in various labs is due to generous patients who've been willing to give some of their melanoma tissue sample when the surgeon cuts it out. A piece of that goes to the laboratories here, and we spend a lot of time trying to use the samples that we get from patients to better understand the condition and ultimately try to have new ideas for new drugs that can make their way through the pipeline and ultimately be in interventional trials. So a whole range.
Hi, just a little quick comment. On TV this week, a gentleman was going through a trial for stage 4 melanoma at Johns Hopkins, which his body is now clear of the melanoma. But because the money has been frozen at NIH, his treatment has been stopped. So could this happen at UT Southwestern?
I would say probably all of us could comment to different degrees. Research is funded in lots of different ways across the world and across the country. Here at UT Southwestern, we have a lot of research that's funded by patients, by generous donors, by the state of Texas, by the federal government, including the National Institutes of Health. Many of us are nervous about a lot of the cuts that have been made. The president at UT Southwestern has, sent out a lot of information that's publicly available that the loss to our institution could be on the order of $90 million a year from some of these proposed cuts that are currently happening in court. A lot of the work we do here depends on funding. A lot of the things that we do are not necessarily money makers because we don't know if these things are going to work. It involves inherent risks and taking scientific risks and trying things that may not work the first time. So I think all of us are a little nervous about what this means for the research community, but at the same time, UT Southwestern and the Cancer Center we are committed to patients. This is the mission that all of us have. And so, we are ultimately partners with not just patients, not just with grant funding organizations, insurance companies, all of these things. We do whatever we can to put patients first and make sure they get the treatment they can. So I hope not.
And I do think in terms of the comment that funding comes from a bunch of different places, a lot of the active clinical, at least interventional trials that we have ongoing are at least partially, if not completely funded by the pharmaceutical companies we partner with to run these studies. So for a lot of those studies that we have actively ongoing, we don't anticipate huge changes to our ability to be able to keep patients on their treatment plans.
And I would add, I think, so to not to get into politics, but disease doesn't know allegiances and it doesn't know how people vote. The challenge here is even clinical trial companies, all studies in the U.S. run through the FDA. They are registered, they are approved, they're deemed clinically and scientifically sound, and that they're asking the right question, and we're not hurting people unnecessarily by creating these studies. And we are a comprehensive cancer center here. We're NCI designated comprehensive cancer center. This is also an NIH institute that gives our funding. It's what allows the cancer center to bring folks like us who really want it to ask these questions and to be proactive and take care of patients in this way. So you guys are the advocates for yourself, but also for the future patients that are coming. And being able to say, hey, listen, there are just some things that we do need this funding for. It's really important. It's not a line item. Your life is not a line item. And I think only you guys as patients and families and caregivers can really advocate for that, because at some point providers are limited in what we can and can't do. And that's what I would say.
I just had a question. First of all, thank you guys very much for putting this together and giving your time to educate the community. Earlier in one of the presentations, you mentioned treatment for scars, and there was some additional things. And sort of, if this is non-melanoma skin cancer, but thoughts quickly on IG-SRT, doing that instead of surgeries. I know it's a little off topic, but if just some quick feedback.
Yeah, so we have, that's a great question. So there are some options in terms of utilizing, instead of cutting different non-melanoma skin cancers out, or even some very, very early melanomas, about utilizing various radiation techniques to try to remove those and improve cosmetic outcomes. I will say, I think my memo for that right now is just proceed with caution. There are a lot of people out in various places offering these types of treatments, and some are more skilled and some of these are more proven. Some of the variety of ways these can be treated are very different. We do have a special brachytherapy program here at UT Southwestern, where we have one of our radiation oncologists who provides a very special type of radiation for patients with non-melanoma skin cancers, or some very, very special cases of early melanoma where that's being utilized. So my main piece of advice would be, I think there is an opportunity there. More studies need to be done. And if you are going to proceed with that, I would recommend proceeding at a place with a strong radiation oncology program and a lot of skills and knowledge.
I have a question for Dr. Johnson, if he's online. Dr. Johnson?
Yes, I'm here.
Okay. In an effort to mitigate the amount of side effects that you get with immunotherapy in any of the trials, or all of them, if that's the case, have markers been measured in patients that don't have clinically overt autoimmune disease in order to correlate things like ANO, rheumatoid factor, HLA-B27, C-reactive protein for inflammatory response, that sort of thing that would give you an idea that maybe there's something subclinical going on, and maybe those patients would be at higher risk?
Yeah, that's a great question. The idea that you can figure out which patients might be at risk. There's been a handful of limited studies. So for example, if people have anti-thyroid antibodies, there's a very high likelihood that they're going to develop hypothyroid. So that has been shown, but things like ANA and rheumatoid factor, in terms of limited studies, those have really not shown a whole lot, unfortunately. So, and the thing that makes it difficult is that even patients that do have a clear autoimmune disease like rheumatoid or something else, Crohn's disease, even many of them don't have side effects, which you would think those would be the patients, if you're going to find a high risk patient population, those would be like front and center of the group that would be at risk. And in fact, a lot of times their underlying disease will flare, but it's actually, they don't really get other types of side effects at higher risk than the rest of the population. So even the patients that are the most high risk don't still often don't have side effects. HLA-B27 has been checked and really did not correlate with toxicities. We and others are doing sort of trying to get more sophisticated in terms of doing polygenic risk scores. So thinking about, whole sets of genes that may be upregulated or downregulated, thinking about a more broad assessment of HLA types. I would say so far those things have shown some fruit in terms of picking patients that are a bit higher risk. But still hard to, if somebody's got to say 30% higher risk of colitis, you're probably not going to withhold treatment. So we're still in our early stages of trying to predict which patients are going to get side effects. But yeah, great question.
Yeah.
I think there's two other questions.
Go ahead. Two quick questions. Dr. C, regard to ocular, I've heard the word shadowing a couple of times, and I was really curious what that means in regard to vision and or if that's the same thing as darkening.
What was the word again?
Shadowing.
Yeah, I think the shadowing effect is where it kind of either curtain drop or shadowing effect. And this is, again, coming from a non-ophthalmologist, so I completely caveat that. I think the perspective there is your retina has these directions where light comes in and is refracted back out and goes against the lens, and that's how we see what we see. And some of that shadowing is created where the lesion location is in a place where your eyes actually perceive that deficiency of that empty hole or empty space. And it may not be a full loss of vision, but it's a partial loss of vision in that area.
Okay. And then Dr. Gill, a question for you is, my allowance, how long can I really stay outside or go outside in the sun without having to put sunscreen on? Or is it an hour, 2 hours?
So, okay, great question. So a lot of it, I would say one size does not fit all. Some dermatologists would tell you never. I'm not quite that strict, but I would say a lot of it depends on two things: the UV index. So, if you're going out, and you can look a lot of times at your Apple Watch, see what the UV index is. If it's 1 or 2, if it's nighttime, I'm not too worried. But if you have really, really, really fair skin, if you're the kind of, one size does not fit all. Some people, can go out in 30 minutes and burn. And if that's you, the sunscreen needs to go on. You got to seek the shade. But for the most part, it's a combination of that UV index and your natural kind of skin protection.
I have a quick question. I'm a cancer survivor, immunotherapy 11 years ago. Should I have a recurrence, does that impact the potential treatment options that you could offer me?
Yeah. So the question is, I've had a very long response to immunotherapy, but 10 years later, I have a new diagnosis, maybe a new primary or maybe a new metastatic site of disease. So I would say, given the length of time between when you last had your treatment, I think you start over with a clean slate, and we can generally consider all options. We've seen studies where patients have benefited from treatment and were off for, more than 6 months, a year, 2 years, and sometimes even 10 years, where they've been reinduced with the exact same treatment and have had a benefit. So, we think that these immune checkpoint inhibitors reprogram your immune system so that there's a memory sort of component to it. But just like vaccines, sometimes you need a re-challenge to get the immune system going again. And so given that length of time, we certainly would think these options are available.
My question is, you mentioned, I'm sorry, I'm ancient. You mentioned tissue being used in clinical trials. I'm a clinical trial veteran. Have I been asked about using my tissue, or is that up to the patient to say, I would like any tissue that can be used to be used?
Most clinical trials will have that kind of embedded in the forms that you sign, the consent forms that you sign, saying, okay, I would like to have my tissue donated and used for science. Many people here at UT Southwestern are, when they go into surgery, we have a whole tissue banking program here. And so people get asked at that time point.
And some trials do ask to collect additional tissue that would be not necessarily part of your standard of care approach. So if you were getting a surgery, then to already have collected as part of that, but this would be additional biopsies. And these are written into the protocol. They are specified, though, that the patient needs to be agreeable. It needs to be clinically safe. And so there's always caveats to that. But it is highly encouraged that it gives us an opportunity to learn more than what the study was set up to do. And probably Dr. Johnson would know, after many years of doing this, sometimes the best things we learn are 5-10 years after it's already been done. And we go back and learn. And without the tissue, we don't have that way of doing it.
I don't have a question as much as a comment, but as a living representation of many of the slides we saw today for the last 11 years, I just want to say thank you to you, your colleagues, and the doctors that have come before you. I absolutely would not be here without you.
I'll start. I have 2 questions here. These, Dr. Johnson, I'm going to direct these to you, and I'll paraphrase. So one is asking about side effects from immunotherapy. What do they mean? Is there any correlation to having a side effect and potentially having a benefit or predictive benefit of the immunotherapy? And the second one, in line with that, is someone says it had a grade 2 response, and potentially, I'm assuming, a toxicity to ipi/nivo. And now Opdualag is being suggested. Is it likely to have the same side effect issues? And kind of leading in with what about re-challenge with immunotherapy post side effects?
Yeah, a couple great questions. There have been a number of studies that show that there is this general trend that folks that have side effects have better responses. Now, there's a lot of complicating factors there. Of course, people who get treatment longer because they're responding also may be more likely to get side effects. So it's a complicated question to ask. But still, if you actually drill down into the data pretty deeply, as many of us have done, there is a correlation. So it's certainly not a guarantee. If somebody has a side effect, it doesn't mean they're going to respond. Or if somebody doesn't have a side effect, it's no guarantee that they won't. But if you certainly look, you're probably 10 or 20% more likely to respond if you get a side effect, and perhaps 10 or 20% less likely if you don't. But again, there's still a lot we need to do to understand that more. To the second question, we've done a study where we looked at folks that had side effects with Yervoy, with ipi/nivo, with Yervoy and Opdivo, and then continued, then restarted the single drug. So just restarted either Opdivo or I should say nivolumab or pembrolizumab. And only about 20% of people had the same side effect come back up. So it's not impossible that the side effect would reoccur, but it is actually fairly unlikely. I'd say the one perhaps caveat to that would be a pneumonitis. So for folks that get inflammation of the lungs, it's probably a bit more likely. It's still not 100%. It's probably more like 50-50. I would say colitis is even less likely. So for folks that get inflammation of the colon, it's actually very unlikely that will recur. At least in our study, it was only like 1 out of 30 patients that had colitis on the 2 drugs, got it again with the 1 drug. We don't have that data as much with Opdualag, with nivolumab and relatlimab, but most of us think of it a little closer to single agent than the combination ipi/nivo. So I think, overall, the likelihood of a side effect coming back is not terribly high. Again, the details matter, how severe the side effects were, how long it's been since. There's some things that can make it slightly more or less likely, but overall, the likelihood of it flaring back up is not terribly high.
Yeah, I have a question too from the online group. I guess the question is, how long can you expect the BRAF treatment to keep working? So we did touch upon it a little bit. So, these targeted therapies in general, not just only in BRAF, but other mutations across cancers, there seems to be a resistance mechanism. So, like we talked about, these driver mutations leads to an addiction to this pathway. Sometimes the tumor finds a way to be less addicted or finds a new pathway to grow. And so in terms of the BRAF MEK experience, it looks like for most patients, so that means like 50% of the patients, that time point is about a year. But we have seen in a lot of our clinical trials, there are these long-term responders, and we have some in clinic where they've been on BRAF/MEK inhibitors for, 3, 4, 5, 6 years and are still doing well. So there is a subset of patients, for whatever reason, that continue to do well. There's ongoing research into discovering kind of what are the factors that lead to these patients doing better than others.
Great. I have two questions here related to ocular melanoma. One is saying, I heard Dr. Gill says that lighter skin and eyes put me at higher risk for skin cancer. Does this mean I'm also at higher risk for ocular melanoma? So it's a great question, right? I think I would separate, as I mentioned in my slide set, there are trends and then there are risk factors. And I think if you talk to oncologists, we think of risk factors, at least are things we try to encourage are reversible. So those are things that you could make a change in your lifestyle that would then alter that risk. There are occasionally genetic risk factors or predispositions, and that's a slightly different part where we're almost thinking more about, do we need to do something else? It's not about taking something back, but actually doing something else proactively to try and surveil or monitor. We can't change the underlying risk, but we try to discover that disease sooner. At this time with ocular melanoma, there's still not a clear, we wouldn't go around screening everybody for this, but generally, I think I definitely thought about this. I've been offered these retinal scans every time I go to see my optometrist for contacts, and I never thought about it until finally saw a photo of a pigmented lesion, and I was like, actually, maybe now I will pay for that $30 that they said, do you want to stay for 30 minutes and get the back of your eye looked at? Because it did jar me into thinking maybe that was the only preventative thing I could do, and so I think no, it's not something that I would lose sleep over. It is, especially with the rarity of these, we still just don't have guiding factors to say, okay, this is somebody that's higher risk, barring those very rare genetic syndromes. And those patients know who they are. It's familial. They're born into it. Their parents have been getting screenings, and so they know they need to get screenings. And if you don't know anything about that in your family history, then you're not one of them. The other question was about histotripsy and alternative, I think, options to local therapy versus the radiation therapy with the plaque or surgery that I had discussed. In general, those two options are the standard of care. There are also some data for external beam radiation. There are always new therapies that are evolving. It's really two parts. One is to shrink the tumor. The other part is to kill off those cancer cells, any residual cells, so that they cannot spread through the bloodstream and set up shop elsewhere. Histotripsy is something we get, and maybe Dr. Wang could even chime in as well, or Dr. Johnson. I get questions about this, not just for the eye, but other sites of disease. This is an evolving modality. It's another intervention, just like radiation or surgery, for a local therapy. I think where the data sits, to my understanding, is it is not a curative strategy for a cancer. It is a tool that can be used in the right setting. But if we have a patient with a local uveal melanoma, you want to offer a cure for the eye. You want to offer a local cure. So that is not something that local recurrence and leaving cells behind is not something that is a concern.
We have another online question here. This is from someone who said they have had 9 melanomas removed, which were all caught early with no radiation or chemotherapy needed. And then they said they also have had 11 severely atypical moles removed. Do I need to see an oncologist or remain under the care of my dermatologist? So, we do have patients that have multiple primary melanomas on their skin that get caught. We use a lot of the staging guidelines to decide at what point does a patient need to go to see an oncologist to have further evaluation. And so it really depends on what the staging was of those, but assuming that all of these were very early melanomas caught early, there's not necessarily a reason to go see an oncologist. I will, however, come back to the point that we made during the conversation about cancer genetics. If you've had 9 different melanomas and you've had a lot of atypical moles, I would recommend you talk to your dermatologist just about potentially being evaluated by cancer genetics to see if you may have one of these genes that run in families that are making you predisposed. As I mentioned during the talk, you still will need to continue getting, regardless of your gene status, you still need to continue getting seen by a dermatologist, but it can make a big impact if you find out that you have a gene that also puts you at risk for something like pancreatic cancer. We have a program here, a pancreatic cancer prevention program. So patients who do turn out to have some of these genes that put them at risk for both melanoma and pancreatic cancer can get appropriate screening. Because unlike melanoma, you don't know if you're developing a pancreatic cancer when it's early, so you need to be appropriately screened. So I would encourage this person to talk to their doctor about cancer genetics screening.
I called him and, that was 30 years ago. And nothing has changed over the 20 or 30 that you take it off of. And I have all these scars. And I'm like, there's got to be a better way. And I know, Dr. Gill, when you're looking at that mole, in your head, I can tell what Dr. says. She won't say it, but she's going to tell. So and I go, oh, and that's positive. I know. And sure enough, I pulled up on the website before she even called me. It was positive. But my concern is, isn't there some better way to take those off? Like, instead of scraping or scooping, just go ahead and take the white area incision now. Get it, and punch it up. Get it over with. Come back. Be a curious blind chrome.
So I was asked to repeat the question, and I'll summarize, I guess, by a couple things, which is, what do we do about all of the scarring that's taken place? Is there a better way? There's a couple different issues in the mix of, is there a better way to sample that you don't have to cut? Is there a better way to manage the scars? And we can both take this maybe from the different angles that we have and see this from. There are a lot of people trying to find new ways to sample whether something is a melanoma or not. I will say also, proceed with caution. I don't think the data is there for some of these, like, oh, don't actually cut on your skin. There's other sampling ways. I still think the best way to know if something is a melanoma is to take a little piece of it to figure that out. I will say we have come a long way in terms of doing full body photography, doing photographs. I really it used to be 20 years ago that if anything looked abnormal, it would get cut off. And there's patients that have dysplastic moles with 100 biopsies. We do not do that anymore. Now we try to really follow people longitudinally. If we try to recognize, okay, this is a person with abnormal moles. Yes, if we biopsied these, they'd all come back as slightly abnormal, but they're not melanoma. We will watch them closely. So a lot of how often we biopsy people and cut on them is less. That being said, too, I will say there are a lot of treatments for scars. Some of them the surgeon can talk to you about. Some of the time your dermatologist can inject medications to flatten out scars. Sometimes there's lasers to help improve the appearance. But I'll let Dr. Dan take some of that.
Yeah, I think to kind of two different issues. So if you know that you're someone who's a keloid former, which is one of those hypertrophic scar formers, that's something that if you're having a procedure or surgery, I would mention to your surgeon ahead of time, because at the time of the surgery, they can actually do various things, primarily inject a steroid to try to help prevent that from happening. There are also, options of things like scar revision. So for melanoma surgery, especially, a lot of times when we're having to remove a big chunk of tissue and really pull things together, we know that that scar is probably going to widen and not be as cute or pretty as a scar of, somebody who had surgery that didn't have a lot of tissue removed. So, I have patients who I say, let's not really think about this for probably the first 2 years at least, but if you have a widened scar, it's something that even actually another surgery just to remove that scar now that's under less tension could help it heal better. More to your question, I would not recommend, I'm in Dr. Gill's camp of really a biopsy is often unfortunately what we need to do. The downside of doing a bunch of these excisional biopsies or excisional lesion removals is one, if we find out that it is a melanoma and it's a deeper melanoma, you probably should have had a sentinel lymph node biopsy procedure done at the same time. Can we do that after the fact? Yes, we can, but is it probably better to do it all at the same time? Probably is. And if we have to go back in and let's say something was actually a surprisingly deep melanoma, needs a 2 centimeter margin, and you've already had a somewhat sizable surgery the first go round, I actually have to do my margin around the whole scar, not just around the spot. And it's in some ways just easier to hopefully really get the right diagnosis and do the right therapy all at the same time rather than kind of have to put the pieces together after the fact. And unfortunately, that sometimes does mean multiple biopsies. Yeah, so no primary site melanoma is something that probably you actually encounter more than I do. But so what this means is a patient who has evidence of a metastatic site of their melanoma, most frequently lymph nodes, where you can't actually find where the melanoma started. So first off, if you are somebody who falls into that category, you need to make sure you're being evaluated for that primary site by someone who really knows what they're doing. And I say that to say we sometimes have had our dermatologists find lesions that have been missed elsewhere. You also need to be seen by someone who knows that they need to be looking in kind of the atypical places, the eye being one of them. But also these could be what we call mucosal melanomas, which are things that could happen in the mouth, in the vaginal area, in the anal area. So until you've had all those areas thoroughly evaluated, we can't really say you're an unknown primary. That being said, there are plenty of people that fall into this category of we really can't find it. There's a lot of kind of theories behind why that might be the case. Primarily, we think that maybe your immune system actually fought off the primary melanoma, but the melanoma that's made its way to the lymph node or elsewhere, not so much. The good news about these patients is that their survival and their response to therapies and things like that actually tends to be about the same as those who have a known primary. So while it is, comes with some complicating factors, we don't actually have to manage it often dramatically different than our patients where we do know where it started.
You're talking about the family cancer genetic testing. That's a great question. And I will never, ever claim whether something is covered or not covered because I never, ever will know. And things are constantly changing. But what I will say is I'm going to put a plug in for our cancer genetics clinic here. They are absolutely amazing. And I know that I've had many, many patients that get tested here and they work with your insurance company. If your insurance doesn't cover it, they often have a lot of ways they're able to get it for a very reasonable price. So I would always encourage people to come and get plugged in.
All right, well, I think that wraps it up. Thank you guys so much for attending, and those that are online, we really appreciate you guys.
And I will say that we have our clinic staff sitting in that row over there. We really can't do what we do without their support as well. So give them a round of applause.